murmur and the RVOT is here, and there is a good murmur across it, that means the pulmonary artery blood flow is good. So even in the presence of a pulmonary artery blood flow, the patient is cyanosed. That means either the patient has an increased QP-like situation or transposition-like physiology at work, or a patient has an admixture physiology at work. That is why I introduced the three concepts, like there has to be a step down, or there has to be admixture physiology, or there has to be a transposition physiology. For example, a DORV can have an unfavorable steaming or can have subpulmonic VSD. So if the patient has a subpulmonic VSD, there is almost behaving like a TGA physiology. Subpulmonic VSD, what happens now? Subpulmonic VSD, your LV blood is going into PA and your RV blood is going into aorta. Again, happens in TGA. The pulmonary blood flow is very good, but the patient is blue because there is transposition physiology at work. Understand? That's why I told, but maybe I didn't get it across. So this is the reason for this. Very good that you clarified, because many are not conversant with this. Not even some of the examiners.
One more question. Anyone?
We'll ask them in the exam, sir.
Okay. So sorry. Thanks. Okay. So moving on, I'll request Sandeep to cover the last topic as far as the lecture is concerned, that RCM versus CCPA. Again, a very, very common thing during the exams, often asked, and majority of you guys fumble at that point only. So I request that go through this lecture nicely.
Oh, thank you and good morning. Good morning. This is actually one of the toughest differentials, and Shiv Kumar is my batchmate. He gave me this topic. I tried to run away from it. I said, look, I can't come on Saturday. So he said, okay. He put me on Sunday when I was to come. But believe me, I'm almost learning along with you guys as we go along talking about this. There are two important articles which I can share with the company people, and they can share it with you. There is a 2016 JACC article which talks of differentiating between chronic constrictive pericarditis and restrictive cardiomyopathy. And there is an article from The Heart, which is the British journal. And a lot of what I have taken here has come from these two sources. So the important thing is, first of all, why is it important to differentiate between these two conditions, constrictive pericarditis and restrictive cardiomyopathy? The first thing is, and the JACC article writes that as the first line, this remains one of the cardiovascular medicine's most complex challenges to differentiate between the two. Both the conditions have impaired filling and predominant right-sided features. The important thing is constrictive pericarditis is a reversible disease, whereas in restrictive cardiomyopathy, by and large, it's a inexorably unrelenting course, and the patient is likely to, have not a very good prognosis. And constriction, as we know, is basically encasement of the heart. The pericardium gets thickened. It does not allow the heart to expand. Those of us who like to study cardiovascular physiology, we understand that tamponade can occur even with 50 ml to 100 ml of extra sudden bleeding into the pericardium. But on the other hand, all of us have tapped at some point of time in our lives or the other very large pericardial effusions which are going into tamponade. And this phenomenon of pericardium getting stretched out over a period of time is called creep. And this is mentioned in Brown-Wall's textbook of physiology. So in chronic constrictive pericarditis, on the other hand, there is a thickening of the pericardium, so the creep never happens. It cannot happen because of restriction by itself. Whereas right restrictive cardiomyopathy is a disease, as we understand, of the myocardium. Now, please forgive me because there are going to be some as I present along, because it is difficult at times to tease out each point, and so when you cut paste, there will be some bits of overlap. So bear with me for that. Now, as far as the etiologies of these two conditions is concerned, in our country, the most important cause of constrictive pericarditis, as we all know, is tuberculosis. Whereas in other countries, and at number 2 in our countries also, you would have problems like due to radiation, due to connective tissue disorders, or patients having undergone previous cardiovascular procedures. Restrictive cardiomyopathies, on the other hand, they have a separate genetic group of diseases which cause it. In the rest of it, most common is idiopathic. There are specific like amyloidosis, and we are aware of conditions like endomyocardial fibrosis and endocardial fibroelastosis. This is an elegant article it's a review article on restrictive cardiomyopathy, which tells you that you have, certain genetic syndromes and non-genetic syndromes in each category. And amyloidosis and some storage disorders and familial restrictive cardiomyopathies are the important causes in the West. We have, more importantly, the tropical endomyocardial fibrosis as the cause of restrictive cardiomyopathy. In this slide, I have tried to, recapitulate with you guys the the jugular venous tracings that we all know. So the first thing that we see, here is the A wave, which corresponds to the atrial contraction. After that, the atrium starts to relax, and so we have the X descent. As soon after the atrial contraction, the ventricle starts to contract, and during the phase of isovolumetric contraction of the right ventricle, there is a bulging of the AV area into the RA, and that causes the C bump, as we know of. After the X descent is completed, we have continuous filling of the ventricle, and after some time, this filling completes, and we have the V wave. And when at the end of the ventricular systole, the ventricle again relaxes, we have the Y wave. So this is the normal physiology. Now, in case of constrictive pericarditis, these two are extremely important. As we know, when we inhale or during inspiration, the venous return to the right side of the heart increases. So in case of a normal person, this leads to actually transmission of the intrathoracic pressure from the heart. It gets transmitted to the heart, and so we don't get any rise in the JVP as we inhale. In case of constrictive pericarditis, we have this Kussmaul sign, which is increasing JVP with inspiration. Now, there is another important sign which is called the Friedreich sign. In constrictive pericarditis, we have a prominent A wave, we have a prominent X descent, and we also have a prominent Y descent. So if you have two prominent descents, then it is constrictive pericarditis. It is also important to remember that the Y descent is a very sharp descent, and it has been described as a flicker. And this flicker is what is called as Friedrich's sign. That is something that some of the examiners may like to ask you. We also need to understand that we have a good X descent because the atrial contraction produces a reasonable A wave. And after that, as the ventricle is, as the pressure descends into the ventricle, you get a prominent X. But over a period of time, the atrium is not able to accommodate the blood which has been coming into the right atrium. And so you also have a prominent Y wave. So please remember, if there are two negative waves present, the X and the Y, your patient has constrictive pericarditis. In case of in case of restrictive cardiomyopathy, there is a single wave and that is a Y wave. The difference between the Y wave of constrictive pericarditis and restrictive cardiomyopathy is also in the type of Y wave that you see. In case of constrictive pericarditis, you will have a flicker. And that particular sign, as I said, is called as Friedrich's sign. So this shows the right atrial pressure tracings in cardiomyopathy and also in restrictive cardiomyopathy and constrictive pericarditis. Now, the blue ones are the ventricular tracing, and the red one is the the red one is the right atrial tracing. And as we can see on the left side is constrictive pericarditis. You have a prominent X descent, and you also have a prominent Y descent. And we also note that just after the Y descent, there is a plateauing of these, what is known as the square root sign. The square root sign, however, is not a distinguishing feature. It is also present in case of right-sided cardiomyopathy. So what distinguishes is two waves, X and Y, constrictive pericarditis, only Y, restrictive cardiomyopathy. Between the Y waves, why is it important to know? The importance is that if your patient develops atrial fibrillation, then the X descent might go away, but the flicker still continues. So if you have a single Y wave and you want to differentiate between the two, this is the way. Square root sign does not help you in distinguishing between the two. There is, because the heart has been encased, there is also something called ventricular interdependence, which is prominently seen in constrictive pericarditis and less prominently or almost negligible in right-sided cardiomyopathies. So I'd like you to focus on these gray areas. So there is a lot of variation between inspiration and expiration. And if you focus on these gray areas, there's a lot of differentiation between the pressures in inspiration and expiration. And that is the feature of constrictive pericarditis. And the in restrictive cardiomyopathy, that variation is not really present. So if we try and summarize these findings, if you have prominent X and Y descent, it is likely to be constrictive pericarditis. If you have the other thing, as we noted, is equalization of left and right-sided filling pressures. That is again a feature of constrictive pericarditis, and we'll discuss a little bit about this a little while later. Square root sign is again present in constrictive pericarditis more consistently. However, it may also be present in case of restrictive cardiomyopathy, and it does not help you in that. Because there is a equalization of the diastolic pressures, so the filling pressures of more than 25 millimeters are rare in case of constrictive pericarditis, whereas they can be there in restrictive cardiomyopathy. Pulmonary artery systolic pressure, some books give a cutoff of 50 millimeters, as in this case, and some give a cutoff of 60 millimeter. Suffice to say that if the pulmonary artery pressure is high, pulmonary artery systolic pressure is high, then it is unlikely to be constrictive pericarditis. It has to be restrictive cardiomyopathy. And the ratio of right ventricular end diastolic pressure and right ventricular systolic pressure is usually more than 1/3 in case of constrictive pericarditis. And as I said, the left and right ventricular interdependence is discordant in constrictive pericarditis. So when the right-sided ventricle is small, the left-sided ventricle becomes big because the septum keeps on shifting. So it is actually a complex interplay between the respiratory variations and the venous return variations, and also the way in which the interventricular septum behaves. And we shall see that a little while later. So clinically, if we look at auscultation, these are diastolic phenomena. So typically, in case of constrictive pericarditis, you have a very early sound, which occurs 60 to 100 milliseconds after the second heart sound. And that's a very sharp sound. And that is why this is called as pericardial knock. In the restrictive cardiomyopathy, on the other hand, you have a little delayed sound, which is like a thud sound, and that is the right-sided third heart sound. Also, please remember that if you have murmurs of MR or TR present, these are very typical of, these are almost never ever there in constrictive pericarditis. So if you find a regurgitant murmur, it is suggestive of restrictive cardiomyopathy. And it is also good to remember that the S4, if you hear a S4, then it is virtually going to rule out constrictive pericarditis. If S4 is present, it is restrictive cardiomyopathy. It is virtually never there in constrictive pericarditis. As far as ECGs are concerned, there are no particular or specific features. However, there are some features which are present in constrictive pericarditis. Please remember that pericardial inflammation can spread into the atria also and can lead to interatrial conduction defects. So you have wide P waves, you have notch between the, in the P wave, and these are low amplitude P waves. On the other hand, restrictive cardiomyopathy is almost always associated with a biatrial enlargement. The LA and RA both are enlarged. Atrial fibrillation can be present in both, but it is more likely to be present in restrictive cardiomyopathy. If left ventricular hypertrophy is present, the features of changes of left ventricular hypertrophy are present in your ECG, then it is restrictive cardiomyopathy. It is also interesting to note that if there is a discordance between the QRS voltage and wall thickness, you should suspect amyloidosis. It is also known that restrictive cardiomyopathies cause conduction defects, ventricular conduction defects, in about 20 to 30% patients, and you may get left bundle branch block or right bundle branch block. But none of these features is distinguishing features. So this is a little busy slide, but this goes on to recapitulate that on clinical examination, Kussmaul's sign, which is paradoxical rise of the jugular venous pressure during inspiration, is usually present. There may be presence of pulsus paradoxus in case of constrictive pericarditis, and both these are infrequent. Kussmaul's is possible in restrictive cardiomyopathy, doesn't distinguish between the two, but it is not very usual to find it in restrictive cardiomyopathy. You find a pericardial knock in constrictive pericarditis, you find a third heart sound, and occasionally a fourth heart sound in case of restrictive cardiomyopathy. As far as the cardiac catheterization is concerned, we all know that equalization of diastolic pressures in all the four chambers. My examiners were very fond of asking which phase of diastole. So I highlighted this. It is the end diastolic pressures. Please remember, when you say there is an equalization of diastolic pressure, your examiner is bound to ask you which part of end diastolic pressure. Is it the mean diastolic pressure? Is it the early diastolic pressure? It is the end diastolic pressure which has equalization, and the difference between the various chambers is of less than 5 millimeters of mercury. It is also important in the same breath to remember, although cardiac catheterization is no longer held mandatory, but in some institutions, like in my place, the surgeon always demands a cardiac catheterization before going for surgery for constrictive pericarditis. So you don't need to do a left heart catheterization in these patients. You can measure the pressure in the right atrium and the right ventricle, and then do the pulmonary capillary wedge pressure, which will give you the LA pressure. So if you have 3 of the 4 chambers where you have equalization of pressures and diastolic pressures, that is suggestive of constrictive pericarditis. Echocardiographic features we will see a while later. The dip and plateau form or square root sign, that is another important thing. There are no biomarkers. Please remember, if somebody asks you, is there a biomarker that differentiates? It is important to remember that in constrictive pericarditis, you do not have a rise of biomarkers. Whereas in restrictive cardiomyopathy, you can have a rise in biomarkers like NT-proBNP. So typically, if your patient has an NT-proBNP which is more than 200, it virtually rules out restrictive cardiomyopathy. And typically, the NT-proBNP levels in typical restrictive cardiomyopathy are around 5 to 600. And the reason is that there is a atrial enlargement which is there in restrictive cardiomyopathy. So when we do catheterization, the 2 other things that we look at is, as I said, the equalization of ventricular end diastolic pressures. They should be less than 5 millimeters, and some books, as this article says, 4 millimeters. And also the ratio of the right ventricular end diastolic pressure to systolic pressure. And that is, again, what I already said. It should be less than 1/3. The figure given here is 0.38. This is a problem in medicine. You don't have very definitive values, and you will have a slight difference in the values from one to the other. Now, let us go to the echocardiography, because echocardiography is another thing which helps you to distinguish CP from RCM. As we see here, this is what is known as the respirophasic septal shift. If we see here, during inspiration, the septum is, this is M mode, and during inspiration, the septum is shifting towards the left ventricular side, and it shifts to the right ventricular side during expiration. And this particular portion has been magnified here. And what you see here, the shudder that takes place is the typical septal shudder that you see in constrictive pericarditis. There are other things. So ventricular septal defect, the, the medial E prime velocity and the medial E prime to lateral E prime, velocity ratios, and hepatic vein diastolic reversal velocities and forward velocities. These are important, and the sensitivities, specificities, and positive predictive values are given here. It is important to remember in this that what are the typical echocardiographic features? You see there is a lot of variation, respiratory variation in the mitral inflow that is seen here. We also see that there is a diastolic flow reversal, which is largely expiratory. It is an expiratory hepatic vein flow reversal, which is seen. It is also noted that the E prime is less than 15 centimeters, and in the lateral mitral annulus, the E prime values are even lesser. So these are some of the features of constrictive pericarditis. On the other hand, if we look at restrictive cardiomyopathy, it is important to note that there is a inspiratory diastolic flow reversal. Look at this. This is an inspiratory diastolic flow reversal. The mitral flow velocities do not show any significant variation, and the lateral mitral annulus is showing even lesser velocities. The typical feature that you will see on echocardiography of restrictive cardiomyopathy is this typical biatrial enlargement, which is most distinctive. The other features like left ventricular hypertrophy can be confusing. So this is a little busy slide, but it is, I think, the most important slide. When you look at echocardiography, you look at the median E prime velocity. If it is increased, it is favoring constriction. If it is markedly low, it favors restriction. Medial E prime to lateral E prime ratio, if it is increased, it favors constriction. And if it is decreased, it favors restriction. If there is a if there is an increased respiratory variation in the mitral inflow, it favors constriction. And if there is an increased septal shift, that also favors constriction. And if in the hepatic veins, there is a decreased forward velocity and increased expiratory diastolic reversal, then it favors constriction. If it is a inspiratory diastolic reversal, this favors constriction. And we shall discuss about the cardiac CT a while later. This is how the X-ray would look like. So you can see that there is the only single thing that you can do is pericardial calcification, you can see. But please remember, pericardial calcification is present in only 25 to 30% of patients of constrictive pericarditis. And this is chest X-ray that is showing pericardial thickness. The same can be done by CT scans. You can demonstrate the thickness of the pericardium, and further down we have CMR in everything right now. So in constrictive pericarditis, you have a pericardial thickening. In CMR, again, you see those septal kinetics very well. So if you are seeing septal bounce and movement of the septum towards the left ventricle and right ventricle, then this is suggestive of constrictive pericarditis. The ventricular interdependence is also in a similar manner. We also talked about atrial dilatation, which is far more common and far more prominent in restrictive cardiomyopathy. Ventricular hypertrophy, if it is present, it is again suggestive of restrictive cardiomyopathy. And if the systolic function is diminished, remember in restrictive cardiomyopathy, you can have over a period of time a little decrease in the systolic function. However, it is extremely rare in case of constrictive pericarditis. And if we see the late gadolinium enhancement, it will be pericardial in case of CCP and myocardial in case of right restrictive cardiomyopathy. This is, again, this is to show you the encasement. This is the encasement of the pericardium that you see in case of constrictive pericarditis. If you have subacute constrictive pericarditis or effusoconstrictive pericarditis, then you will get the presence of, this kind of fluid also in this. This is a little busy, so let me go and shift. So final two slides. As far as the differentiation between constrictive pericarditis and RCM is concerned, as I said, it is one of the most difficult differentials in cardiovascular medicine. However, in case of patient's history, we will find typically in our country, it would be tuberculosis or the patient having received radiation or patient having undergone cardiac procedures. And the fourth common would be connective tissue disorders. In case of restrictive cardiomyopathy, it can be familial, or in our country, we have endomyocardial fibrosis, which is common, and amyloidosis is a third condition that is common. In case of jugular venous pressure examination, we find both prominent Y and X in case of constrictive pericarditis, whereas Y is prominent only in case of restrictive cardiomyopathy. The X may be normal or it may be even diminished. Kussmaul's sign, as I said, is more importantly present in constrictive pericarditis, but it does not make a differentiation from the restrictive cardiomyopathy. As far as the lab and ECG and X-ray are concerned, I discussed all that. The comparisons are non-specific. There are no distinguishing features. However, please remember that the positive features are more diagnostic. So if my patient typically has a very high NT-proBNP, he's unlikely to be CP. If my patient has a pericardial calcification on the X-ray, he's likely to be CP. If my patient has left ventricular hypertrophy on echo, then he's again more likely to have, restrictive cardiomyopathy. As far as the investigations of imaging are concerned, increase in pericardial thickness, more than 4 millimeters, pericardial calcification, presence of some amount of effusion, features of ventricular interdependence. I showed the septal movements. They are extremely common. And evidence of pericardial inflammation on late gadolinium enhancement. These are features of constrictive pericarditis, whereas increase in wall thickness, biatrial enlargement, which is very common in restrictive cardiomyopathy, dysfunction, particularly systolic dysfunction, if present, is suggestive of restrictive cardiomyopathy. And the pulmonary artery systolic pressures, we again discussed that if they are more than 60, then they are suggestive of restrictive cardiomyopathy. And as far as the invasive hemodynamics are concerned, again, the respirophasic ventricular pressure differences are important in case of constrictive pericarditis and also to distinguish from restrictive cardiomyopathy. I thank you for your kind attention.
Any questions?
is it, I think it's one of the most important topic, and invariably you will get a case like this in the examination. And there are so many signs that are there in this differentiation between the constrictive pericarditis and restrictive cardiomyopathy. And he has made it very clear. But anybody has got any questions? I think you have made it very
Yes, sir.
clear and
America.
simple.
आप मत पूछना सर मैं
As a matter of fact, we all come across in our last so many years, all of us have come across the case like this, enigma like this. And we always sat down and sort of put in our brains whether is it a constrictive pericarditis, is it a restrictive cardiomyopathy. And I can tell you now, of course, we have got a cardiac MRI where things become a little bit easier. But otherwise, in the past, the only thing that we could look at the type of pressure tracings that we would get in the pulmonary artery, into the right ventricle, into the pulmonary artery wedge pressure. And echo was not coming forward. So I think we had to literally sort of listen to our ears and some pressure tracings. But I think now things have become a little bit more clear, and a lot of misdiagnosed surgeons had gone in, they opened the chest thinking it to be the constrictive pericarditis, closed the chest saying that it was not a constrictive pericarditis. But I think with this kind of science that he has shown, I'm sure you'll be able to make better diagnosis. But I think your aim is to pass in the examination, to tell all these differentiating signs. That's what you should know. Thank you very much, Sandeep. Now, are we breaking for tea now, Srinivas? Yeah, okay. Thank you.
Request all to have a quick coffee break, and reassemble back in 15-20 minutes maximum.
Okay, so request everybody settle down. This is the time in the last 2 days where your skills will be tested. And of course, in our earlier meetings, we had some very senior and very tough examiners. So this time, fortunately, we don't have, hopefully not that tough examiners, because Dayasagar Rao and Dr. Krishnam Raju, they used to make the student literally cry. So I hope you won't cry, but let's start the things. So we have 3 cases, a long case followed by 2 short cases. We'll stick to the time because we're all running against the time. So 11:15, we'll start with the long case. The examiners are Dr. Palajani sir, Dr. Satyavan Sharma sir, and Dr. Ramakrishna. Okay, so you 3 will be the main examiners, of course, everybody else. Then there are 2 short cases. After the long case, the short case examiners are Dr. Sandeep and Dr. B. Srinivas from Nizams. Has he come? Is he come? Okay. And another short case, Srinivas Kumar, B. Srinivas, Rama, and myself also. So we'll just be around. So start with the first long case. Who's the presenter? Where is the... Oh, you are there? Okay. Sir, you want to sit there? You be there or what? You want to get the chairs here. It's better because everybody can listen to them.
Somebody call me. ऐसा लग रहा है हम लोग एग्जाम है ऐसा लग रहा है we are being exam.
So you don't want the chairs there? Okay. Okay, fine. Okay. So take over, Rama.
The time or not? Is it there? Forty minutes time. Exam by 40 minutes and then have the X-ray ECG and right. Finish by around 1 hour.
Good morning, sir. So I will start with it. 35-year-old male patient, resident of Narsimhapet, farmer by farm laborer by occupation, completed primary schooling, come from a low socioeconomic class, come with chief complaints of dyspnea on exertion since last 3 years. Dialysis. For above complaint, patient was admitted to the hospital 15 days back and he told to have a heart disease for which he required a surgery. And he given an IV medication and oral medication which increases his urine output. And also one pleural tapping was done, around 1.5 liter of fluids was removed, which was pale in colored. Followed by patient felt symptomatically better and he able to perform his daily activity with improvement in his sleep. There is no history of abdominal distension, facial puffiness, pedal edema, no history of angina, syncope, or dizziness, no history of hoarseness of voice, dysphagia, or CVA, no history of prolonged fever or joint pain, no history of cyanosis or any recurrent respiratory tract infection in the childhood. Shall I proceed with past history, sir?
So this is a history of a patient for last 3 years
Yes, sir.
and has been gradually worsening.
Yes.
and recently required a hospitalization.
Yes.
During hospitalization, the patient received IV medication and also required a pleural tapping.
Yes.
So how do you synthesize? What do you understand with the history? What might be happening to the patient?
Yes, sir. So definitely there is a.
Will you like to put it in some hemodynamic terms or in terms of what might be happening? Is the patient getting heart failure? The patient is getting.
Yes, sir. So definite one episode like palpitation is recent onset, followed by development of PND and orthopnea. There are correlating. Like last 6 months he had in PND. Since 3 months he had palpitation and worsening of symptoms like orthopnea, and followed by 15 days back, which is relieved like pleural tapping. Indicate CCF was recently developed, might be precipitating because of the arrhythmic event like palpitation. So likely a stable hemodynamic wise, like any MS or any inflow obstruction that is precipitated because of the arrhythmia, and a patient developing the symptoms now, like heart failure.
You think it's in a bivent? You think it's in a biventricular failure like this?
Sir, in history wise, like pedal edema, ascites per se is not there, but pleural effusion we can consider might be a right heart symptom.
So can it be anything else? Pleural effusion? Even though we think that it could be right heart.
Yes, sir.
But suppose somebody develops pleural effusion because of right heart failure, definitely should have at least some pedal edema or something else
Yes,
has
sir.
to be there.
Yes, sir.
So what are the other possibilities you will consider?
Yes, sir.
Because tapping, pleural tapping is a not common
Event.
presentation.
On looking to the patient, sir, he is totally emaciated, cachexic. So in our country, we should think of tuberculosis the first.
One could be the additional pathology you want to bring.
Yes.
Can this be anything else? Can left heart disease produce pleural effusion?
Yes, sir, possible. Yes, sir. Possible.
Any other possibility? Recent answer there.
Could it be a cardiorenal syndrome where patient has got a renal along with just a cardiac failure patient or some renal
So
disease?
possible in that case, facial puffiness would think, but possible, sir. Pleural effusion because of cardiorenal possible.
Another possibility will always be pulmonary embolism.
Yes, sir.
You can finish the history. Yeah.
Yes, sir. So past history, there is no history of diabetes or hypertension, no history of past tuberculosis or asthma. There is no previous history of hospitalization. There is no history of any taking in monthly regular injection and no history of drug abuse. He is married, having 2 kids, consume mixed diet, normal bowel and bladder habit. He is smoker. There is no drug allergy. Family history is born of non-consensuous marriage, no history of sudden cardiac death in family, and there is no heart disease in the family member.
Summary field.
Yes. So 35-year-old male patient presented with dyspnea on exertion since last 3 year duration, which likely precipitated by arrhythmic like AF like atrial fibrillation with history of pleural tapping likely indicating a congestive cardiac failure.
Sorry for the interrupt. The students for the short cases, Dr. Pradeep Bansal and Dr. G. Kumar.
So from your this history, what etiologies are possible? You got my question?
Yes.
So this is a history which you told is essentially looking like a left heart failure,
Yes.
and you thought the left heart failure was precipitated by atrial fibrillation,
Yes.
by an arrhythmia, most
Yes.
likely atrial. So what etiological groups will come to your mind?
Yes. So as such, there is no history of past rheumatic heart disease, but still 50% cases might not have any history of rheumatic heart disease. We can think of first like rheumatic heart disease in our country, followed by the history is not like long duration, like 3 years of dyspnea only. If it is an MS, I would expect might be a long duration. It could be like MVP, MR might be precipitated by some.
So one is this can be a valvular heart disease.
Valvular
That's
heart
what you are
disease,
trying. It can be a rheumatic heart disease. Any other group it can be?
So MR, like other causes like myxomatous mitral valve.
Okay. So it can be a, let me put it in a more broader way. It can be a valvular heart disease,
Yes.
either rheumatic or degenerative
Degenerative.
or any other etiology.
Yes.
Any other group you
Yes,
will
sir.
consider?
Myocardium problem, sometimes like cardiomyopathy can also be present like this.
Can you think of any congenital heart disease?
Congenital, sir, I specifically asked in history any past, like increased pulmonary blood flow situation. He's denying. if you take that as a soft point, then we can keep as a lower most point, could be a concern.
Do you think of any congenital heart disease which can be present with atrial fibrillation like this? Or would give rise to kind of a biventricular failure like this?
So at this age, like third to fourth decade, we think of ASD, but development of arrhythmia is more after 40 years. Still can be possible.
You can summarize this again, because summary is something that that should get the essence of the case. And can you try, because this is an exercise for everybody. You can summarize it again.
So 35-year-old male patient presented with dyspnea on exertion since last 3 years duration, which precipitated by arrhythmic event, likely atrial fibrillation, with history of a pleural tapping indicating a congestive cardiac failure. My likely diagnosis is a valvular heart disease, likely rheumatic heart disease with severe MS.
Anybody wants to improve it, like anybody wants to, there are some critical essential features that are missing in the summary, which has to be there. So what is the NYHA functional class of this patient? To start with 3 years back,
So
what it has become. That course is not there. That should be out and out in your summary.
initially started
You start
with
with
class
now
2
in class
and
4.
deteriorated since last 6 months.
So your PhD and orthopnea have such critical symptoms that's not missing in your summary. That must be there in your summary. This is an exercise for you, so it's not for just to point out fingers, but it's supposed this is an exercise that you get the crisp case out in that line. So because orthopnea and PND are such symptoms that give you a lot of clues. So what are the congenital heart disease that can produce PND? PND is such a symptom that what congenital heart disease can produce PND? Except for congenital MS, you can't think of anything
Yes,
else.
congenital mitral stenosis.
Stenosis is the only thing. Very unlikely that you will present with congenital MS. So what about pericardial disease? Because only has dyspnea and palpitation, arrhythmic palpitation, AF. So can this be restricted cardiomyopathy? Can this be constrictive pericarditis? Can this be dilated cardiomyopathy?
So restrictive, constrictive less likely because PND and orthopnea is that severity of dyspnea is less.
Suppose what is the LA pressure?
It's same in all.
So it's roughly 25. Suppose RA pressure is 25. LA pressure will be 25. Why there is no PND?
It's because of the interventricular interdependence, the pulmonary veins are outside.
We don't know. We don't understand. Some of the explanation is that somehow PND plays a role in precipitation of. There are theories
Yeah, the
written about
pulmonary
it.
veins
We
are
should know that PND is not so high, and that somehow protects against the development of PND. And it's a long-standing happening, so then lymphatic and other various compensating mechanisms are at work. It's not acutely developing disease. So these are the various things. What about AF in CCP? Suppose this is AF and AF.
Possible.
It's a possible.
What percentage of CCP have AF?
5.
It's uncommon. Like roughly say 1/3, maximum is 1/3 of them can have atrial anemia. So it's again uncommon. So these things will make it CCP uncommon. What about RCM? Can this be RCM? So you said cardiomyopathy is possible. That's why I'm asking you all this.
Cardiomyopathy, yes, sir.
So suppose if this is restrictive cardiomyopathy, can you only develop total deficient not have any condition?
RCMP will be in predominantly RV failure features as like pedal edema and abdomen distension with the pulmonary
Most
symptom.
of the prototypic idiopathic RCMP will be predominant right ventricle valves. You're not getting any features of that. Again, that is unlikely.
Yes.
You are most likely dealing with
Who's actually dealing with the valvular heart
Valvular.
disease of LV side likely to be stenotic lesions.
can this be thromboembolic PH?
Sir?
Thromboembolic PH,
No history of like sudden onset features.
that may not be there. Vast majority of it is not there.
So orthopnea less likely in case of
Orthopnea and TND are not.
TND are
And
not.
right heart symptoms like predominant.
Those are very classical features that take it out.
Yes.
So with the history of PND and orthopnea, you remain restricted to either a myocardial disease or a left heart valvular disease. That on that basis, you can exclude pulmonary hypertension, constrictive pericarditis, pericardial disorders.
What is the mechanism of TND? Why do you get
So
TND?
PAT is because of various mechanisms. Most common accepted theory is because of REM sleep. In case of REM sleep, there will be increase in sympathetic activity, and that because of the tachycardia, there will be increase in the LA pressures, and that leads to this like sudden breathlessness. Apart from this, the interstitial fluids start getting accumulated in the intravascular compartment, and that leads to death. Apart from this, there is decrease in the sympathetic surge during the sleep. These are the three classic mechanisms explaining of PAD.
What are the mimickers of PND? What are the diseases that can be like PND?
So it can be COPD, bronchial asthma, sir, bronchiectasis,
Nocturnal asthma.
nocturnal asthma, sir,
GRD.
or
Kushner,
GRD.
Obstructive sleep apnea.
Yes,
OSA.
OSA also.
So can be.
Yes.
One of the most
Yes,
important
one of the
cause
most-
one has to keep in mind.
What is the difference in history between orthopnea and PND? I'm trying to bring out the common classical questions for
It's
everybody.
relieved by the
Yesterday
upright
we did.
position.
Okay.
In the orthopnea, patients get relieved by the.
Yesterday only actually I talked in my lecture,
PAD,
quite a lot of difference. Tell us for benefit of everybody.
orthopnea is a
Orthopnea
sudden-
is relieved by the sitting upright position. PND usually takes time to relieve. And it develops, orthopnea develop like within a 15 to 20 minutes immediately going to the recline. Whereas PND develop time to develop, like 2 to 3 hours to develop, but can rarely possible, can early also.
What about recurrence?
Recurrence in the one night is less likely because patient again going to sleep for 2 to 3 hours. And that activity of REM will be not there. In
PND is unpredictable, like may not happen again, but
May not
after
happen.
repeatedly happens unless it takes another pill like.
Yes.
I think we can go further.
Examination.
So just before that, what valve heart disease? Suppose we think it's valve heart disease. So is it one valve or two valve or which valve heart disease?
It's a multivalvular heart disease.
Why multivalvular?
So one is patient is having orthopnea PND, so it's LV intro obstruction. Apart from this, patient is also having pleural effusion, so might be associated with the RV, the TR.
It's like MS with involvement of
MRC
DR
involvement.
or less likely like could be other wall also, but as such history not pointing towards that. But most of the time we know RSD is involved with multivalvular disease. It could be think of like LV dysfunction.
So what are the histories in the primary possibilities MS PR? What are the other features that you should have asked? Like some of the things may give you a clue. One thing could be a prominent neck pulse. So prominent neck pulse for a, there is no history of prominent neck pulse. When you are describing no pedal edema, no right hypocaudal pain. No effect.
So
But
general
this
physical
all history can be a single valve.
Yes, sir.
Just a mitral stenosis, maybe mitral stenosis, mitral incompetence, or just a mitral stenosis got complicated by atrial fibrillation.
So what are the other functional classes apart from NOHA?
The Goldman specific class and Brog assess visual analog scale, then Duke's activity.
First as a cardiologist, first thing should be.
NYHA plus
Canadian,
So how the Canadian classification is different from NOHA classification?
they use the objective ways of measuring the height, like walking the.
That's one.
Yes, sir. And they included the strenuous activity in the class 1, that not there in the NYHA class 1.
So there is something called CCS zero has also been described.
Yes,
It is not there in NOHA.
NYHA.
yes, sir.
And anything else? What are the symptoms that can be classified with CCS and that can be classified with NOHA?
So in your CCS, angina is the predominant.
Only angina is
Only
classified with
angina.
CCS.
For
Whereas
chest
with NOHA,
Here angina.
Palpitation, palpitation, dyspnea, fatigue,
So angina, syncope,
Dyspnea,
palpitation and dyspnea. sir.
syncope is there in
syncope
NOHA.
is in WHO for PH
Fatigue
classification.
bleeding.
So what are the four things that are classified in NOHA?
Fatigue, breathlessness, angina, and palpitation.
The WHO should know. How do you classify in a child?
So child we use
So there is Ross classification of the heart failure, while
So there is a
follow-up
modified ROS
Modified
scale,
ROS.
which again uses a similar pattern,
Hmm.
but uses the children activity like
Children's
crying and
activity,
feeding
crying
and all
and
those things. What is ROS score?
Ross score.
The ROS score is an objective score including heart rate and everything in an objective fashion that's used to more for clinical studies.
Clinical.
It gives you some number. So these are the various things you should know about functional classification.
So general physical examination, patient is conscious oriented to time, place and person. He is a thin build and emasticated. Height is 146 centimeter, while weight is 46. BMI is 17.9. Respiratory rate is 20. Pulse is 112 beats per minute. Irregular, variable volume, normal character, normal condition of the vessel wall with no radial or no radiofemoral delay. Blood pressure is 110 by 80 in the right upper arm supine position, while left lower limb it is 114 by 80. Saturation is 98% at room air. JVP is raised pulsatile 8 centimeter above the sternal angle at 45 degree with prominent CV waves. No pallor, icterus, cyanosis, clubbing or lymphadenopathy. Back and spine are normal. Serious inspection and palpation. Tracheus in the midline position. Chest is bilateral symmetrical. Apical impulse is the fifth intercostal space. Medial to the mid-clavicular line. Tapping in nature. Palpable P2 diastolic thrill is present at the left fifth intercostal space. No impulse, scars, sinus or dilated veins.
Be slightly slow, yeah. Be slightly slow, right? For example, you get 1 hour for your long case. If you finish your, whatever you have to talk in 5 minutes, we give examiner 55 minutes of asking questions.
Yes.
When you said irregularly irregular, what do you mean? What is the, why is it irregular?
Atrial fibrillation, sir. Atrial fibrillation.
Why did you just twice? Why don't you just say irregular?
So only irregular, it can be even in case of
So like bigeminous plus or
Bigeminous.
trigeminous plus is irregular, but regularly irregular. Regularly irregular.
Huh.
Like in this case, it's a regular,
Well, sometimes-
irregularly irregular.
Sometimes PVCs can just come at sort of will, at its own will. So it's irregular. So why this is called irregularly irregular? Every time we say atrial fibrillation, irregularly irregular. Why it is twice irregularly irregular?
So first, when we say the regularity of irregularity, if it is a irregularly irregular means that irregularity is not coming.
It is irregularly irregular in the rhythm as well as is irregular in volume.
Okay. Rhythm.
Once volume keeps on changing.
Go on. You said diastolic thrill? What else?
yes, so diastolic thrill is there. Palpable P2 is there. Parational EU of grade 3, and there is no scar sign or dilated veins. An apex impulse is the fifth intercostal space, medial to the mid-clavicular line, and tapping in nature.
Did you get a parasternal heat?
3 by 3.
Great.
3 by?
Great.
Grade 3, sir. Sir, percussion. Upper border of the liver ulnus is the right fifth intercostal space, suggestive of situs solidus. Left heart border corresponds to the apex. Right heart border is substernal, and left second intercostal space is dull.
How did you measure the blood pressure?
We have to take the multiple readings in presence of AF.
In
Did you use
atrial,
a mercury manometer or a aneroid?
so oscillometers.
Oscillometric. So how does oscillometric BQ measurement happen like?
So oscillometer works on the principle of easily
Does
identify.
it listen to corticof sound like you do?
No, sir.
What does it do? How does it pick it?
Presence of the first
Pulse
pulse.
volume, sir, it identifies that oscillometer identifies the maximum amount of that pulse volume that determines.
This all everybody should be clear. Like we cannot. Anybody can be passed without knowing S2, S3. Missing an S3 also can get passed. But however your blood pressure manometer measures blood pressure, we don't know whether you should be allowed to pass a cardiology exam. I don't know. This I think everybody should be clear. So my question why I am coming is, can the whole algorithm, because it looks at the graph and then estimate the blood pressure.
Yes.
Can that work in AF? That is why my question was.
No, sir.
AF is such a common disease and the most important risk factor is hypertension. Leave alone this AF, but at the population level, AF most common risk factor is hypertension.
Yes.
So how can you say that hypertension blood pressure measurement will not be proper in AF?
So we can take the mean of
So
3.
what is the data saying? Can oscillometric blood pressure measurement be predictive in AF? Or good enough in AF?
Take multiple readings.
There are studies that have critically looked into this, and this is quite good. It's reasonable, but you have to measure 5 measures. But you have to use your usual method. So what are the precautions that you have to take when measuring blood pressure in air? Any precaution that you should take when measuring blood pressure in air? Or the usual way you should measure? One is you have to take at least average of 5.
Average of 5.
So anything else you should take? Anybody wants to, how do you measure blood pressure in air? Because AF at times the volumes are variable. At times you can get extraordinarily outliers like sometimes. That means some sound can be out this way or that way. That sound you are supposed to exclude when measuring blood pressure. So read about that. That's something that's very fundamental. That measuring blood pressure in AF is fundamental to cardiology.
Auscultation, sir. S1 is loud and variable. S2 loud P2, opening snap is present.
No, loud P2, what is? Yeah, you cannot pass off like your assessment of JV was perfectly fine. You said all the things that are to be said. Same day S2, you have to say all the things. You cannot just say P2 is loud and move on.
The patient
No.
has a fast ventricular rate, like around 120. It's very like looking
Is it split? Two sounds are
The no split cannot be appreciated.
appreciated.
Is to single split
Not single, like narrowly split.
But say that and then get away. You cannot just eat away a split in final exam. Okay. S2, P2 is loud.
P2 is loud
That's
and
narrow.
a narrow splitting of S2, sir.
Okay.
With opening snap present, sir. So there are two murmurs. First is a mid-diastolic murmur of grade 3/4, low frequency, rough rumbling in nature, best heard in the apex, non-radiating during expirations, best heard during the expirations. And second murmur is a systolic murmur of grade 3/6, best heard in the left fourth if intercostal space, with the diaphragm of stethoscope during inspirations.
Guided lecture.
systolic murmur or pansystolic murmur?
So it was a systolic murmur.
Why are you thinking so much? Right?
Systolic.
It's a pansystolic.
It's a
murmur.
pansystolic
Again, describe it again.
Sir?
Describe that murmur again.
So it's a pansystolic murmur of grade 3/6, best heard in the left fourth intercostal space with the diaphragm of stethoscope during inspiration, best heard during the inspirations.
The murmurs you heard on the right side over the tricuspid area?
Right side,
No, sir.
could not appreciate. Sir.
Anything missing in your MDM description? Again, describe the murmur again.
So it is a mid-diastolic murmur of grade 3/4, low frequency, rough rumbling in character, best heard in the apex, non-radiating during expiration.
Anybody wants to add?
So presystolic accentuation, not
Historic accentuation, then anything else?
So short A2Os in
So you never talked about, you said OS present, but never talked about A2OS gap.
short A2Os.
A2OS gap, what is the A2OS gap?
So it determines the
Narrow.
severity of AS. With the severe AS, the A2Os interval decreases.
Now, what is in your case?
narrow.
I mean narrow, sir.
So you should say that. So with a narrow A2OS gap.
Narrow.
Anything else in the murmur? What gives you murmur quality? What gives you the severity of illness in MS?
So it's a long duration of murmur and
What is
short
the
A2Os.
duration of your murmur?
Long.
It cannot be long.
It
It will be variable,
variable.
obviously. What happens in your long cycle and short cycle, you have to describe.
Yes.
What is happening?
So with the short cycle murmuring, with the short cycle, there will be presystolic accentuation and the murmur will increase during the short cycle, which was like preceded by the long cycle.
So all of these questions, I would request you to think over your echo, because you are all echo generation. You understand echo much better. You've done hundreds of echoes of MS and you are first time after taking a case in your exam. So don't put your money on your observation skill. Put your thinking on your echo skill. Think of the curve, how it is going to be in a short cycle, how the curve is going to be in a long cycle, severe MS, mild MS, moderate MS. You have done, all of you have done hundreds of echoes. So then extrapolate these findings here, what you have been asked.
Sir.
Any murmur you heard on the left sternal border, like aortic leak murmur or anything? Any other murmur you heard?
No, sir. Not.
What is the pitch of a murmur and what is the frequency of a murmur? You are using the word frequency, that's why I'm asking. What is the difference between the pitch of a murmur and the frequency of a murmur? So generally, it's a common mistake in using intracerebrally. Generally, the frequency of the murmur is what is measured. If you are measuring it, you call it by the frequency. If you are hearing it, it's better to discriminate the pitch of a murmur. Same thing, high frequency murmurs are high pitch murmurs, low frequency murmurs are low pitch. So it's better to use the term pitch of a murmur.
Pitch of.
What about the other system?
Other system examinations or respiratory system, there is a left basal crackles are present, sir. And abdominal examination, there is no ascites. Central nervous system examination, no focal neurological deficit and
Is the liver palpable or?
liver is not coming below means not large, not large.
Liver is not palpable.
Yes.
You are getting such a high JVP, very large CV wave. How do you explain liver not palpable?
No pedal edema.
No pedal edema also.
So one thing, patient is well prioritized.
So what is the sequence of disappearance of these three signs? Pedal edema, liver and JVP.
The pedal edema first to disappear, followed by the liver. JVP, pedal edema and liver.
JVP remains the last.
JVP remains the last.
That can be there, but generally you have to be really, as Sir is pointing out, when you have such a large JVP, you are likely to bound to get a liver. Make sure that it's not there at all by your palpation as well as by pulsation.
And did you see for the pulsations also in the abdomen? Sometimes you can see the liver pulsations. In such a case, the chances of liver pulsations, it can be there. So you should even a negative expression. You should tell, I looked for hepatomegaly, I looked for liver pulsations. They are not there.
So when you asked about pre-systolic accentuation, you said yes. Can a patient with AF have pre-systolic accentuation?
Sir, in a patient that
Short
after the short cycle, it's like
Pause.
long cycle followed by short cycle, there can be a persistent accentuation because the gradient between LA and LV will be significantly raised, sir.
So,
Can you summarize and tell us what exactly is your diagnosis?
So final diagnosis is valvular heart disease of rheumatic etiology, severe mitral stenosis with severe tricuspid regurgitation, with severe PH, moderate PVH, in atrial fibrillation, is currently in NYHA class 2 with no evidence of any infective endocarditis in congestive cardiac failure.
Now you said tricuspid regurgitation, but you described the movement. Was it that getting accentuated on inspiration?
Yes.
So it was.
It was it.
And it is being heard best in the apex?
Best left fourth in the postal
Parasympathetic.
space.
Parasympathetic.
Region.
When you get such a severe tricuspid regurgitation, would you expect the liver to be pulsatile?
Yes, sir.
But then you say liver is not palpable.
So in this case, not there, sir, but I will expect the liver should be.
But when you said severe tricuspid regurgitation, I thought the liver should be pulsatile, should be palpable. And especially in the neck vents, you said they're so badly emboshed.
Yes.
this,
Do you think this could be a vital regurg movement?
Sir, MR flow murmur can be there, sir,
Possible,
but there was a
might be like rate
Loud.
is high, sir, in this patient rate around 120. And the murmur, classically like pansystolic murmur, it's relating to the apex also. Apex also it's very visualized. So if you think like severe MR causing the feature of MS like flow can also be possible. Here in this case also history wise also it's not very long dyspnea, only 3 years history. But here the point toward the MS is like severe PH and AF. That would be.
no, we are not disputing MS. What sir is asking you, that rather than TR, is this a MR murmur?
It came with systolic flow murmur, but the only point goes against is there is a loud and variable S1, sir. Along with that, patient is having features of severe PH.
No, but in mitral regurgitation also you can have, if there is a combination lesion,
Apex is
MS
a-
and MR, you can have PH. So, what we are expecting you to tell is, how do you differentiate a TR murmur from a MR murmur? Very simple
Sign
question.
We can explain like
Hmm?
with inspiration is TR murmur.
And during
So
expiration,
And
you,
the
you,
site of maximum.
yesterday we had
murmur.
discussed, you should talk about the location,
Yes.
where will be the location of, where will be the radiation, what will be the effect of inspiration. So all those points you should say.
Yes, sir. Cardiomegaly, hyperdynamic of reference.
Is this murmur getting accentuated on deep inspiration?
Yes, sir.
deep
And
inspiration.
conducted to the axilla
No,
at the back?
axilla back it's not going.
Not more likely to be tricuspid. Yeah. The only thing that is not in concordance with your finding is the liver.
Yes.
You say with the severe PR, I would have expected the liver to be palpable, to be versatile, which I don't, according to your findings, is not sure.
So I think the final diagnosis, most of the things I would agree, but some things are missing. What is the most important thing that is missing? Anybody wants to add?
The history of,
AF with fast ventricular rate or control ventricular rate?
So I've written two atrial fibrillation.
I don't think, I didn't listen.
So sorry.
You told AF, but
AF
not-
said, but it never said fast ventricular rate and control ventricular rate. So what is the definition of this fast ventricular rate and control ventricular rate?
more than
More than
110,
100 is the
fast ventricular rate.
More than?
100, sir.
Where is the definition from? So there's a trial that happened, huh, like control ventricular rate of the fast.
Yes, sir,
ventricular
there
rate.
was a.
You can use
strict
that
and
cutoff
linear.
rate, because
Yes.
there's no other way, the definition of cutoff is there, but there's a control ventricular rate versus strict
There-
control versus lenient control.
Yes, sir, there was a trial that,
You can use the same definition. for
yes,
that.
sir.
So what is his rate?
110, sir.
110
Yes, fast ventricular.
is the fast
Fast
ventricular.
ventricular rate.
Fast ventricular response.
Clearly fast ventricular rate.
Really fast.
So some things I don't agree with. When did he last orthopney?
So when he was admitted 15 days back,
So how can suddenly he become class 2? Just as a cardiologist, we cannot get functional class wrong.
so
So
he was,
somebody comes admitted with class 4 symptoms, he is still on admission. How can he be classified as class 2?
was a class 3 symptoms, like he's still having the failure symptoms. Krebs
He's
has-
class 3 you say. Class 2 you say.
Class 2, I told, sir.
This classification, we cannot get it wrong as a cardiologist. Rest of things are fine. But the functional classification, you cannot get it wrong. So maybe you can say that if he's class 4, he's slightly improved, ambulatory class 4, or his class 3 also we may accept it on treatment. But class 2, I don't think I can accept it. And what about your PVH assessment?
severe PH, severe
He
PVH,
said moderate PVH.
severe PVH.
So he said moderate PVH. That's why the query there. So how do you assess PVH for the sake of everybody? How do you assess the PVH in a given case of an RN?
So PVH,
Multivascular.
so PVH is based on the pulmonary capillary wedge pressure. If
So what is
so
likely?
so here there will be interstitial edema. So the pulmonary capillary wedge pressure will be till 18 to 25.
No, somebody gets orthopney.
Huh.
Somebody
that
gets
is
admitted with orthopney.
PCWP more
Somebody is
than
getting
so that is-
25.
As AF is fast ventricular rate, if this fellow, you cannot clinically classify as severe PVH, I don't think which
So
other
this,
you can
mo-
do.
so this moderate PVH I told currently, sir.
You cannot be so accurate. Let us keep it very simple.
Sir.
Somebody is class 4, somebody has CMD, orthopnea. There is no harm in calling it severe PVH. What are you doing? No examiner is going to tell you, how do you say, why do you say severe PVH? But the reverse is going to happen. And what are the other ways you will classify PVH? Because this is a common problem for everybody.
Amount of the pillows he used, if more than 2 pillows is used to sleep.
Basically, if one is on symptoms, how severe the symptoms of dyspnea?
Yes.
What else you want to use? Classify PVH. Obviously, it depend on the lesion also. Suppose somebody with dyspnea and the lesion is quite also will think of it. And more importantly, the amount of cardiomegaly.
Yes, sir.
Those are the ways you will classify PVH. It's always affected. And the other important way in which you will classify PVH is the reverse calculus from your pH.
Yes, sir. the
Because if somebody has severe pH, it's likely to have at least moderate or severe pH
Moderate.
because of a limited RD.
Will A2OS interval help you in assessing the PVH?
It's a severe it is, then severe the PVH.
Hmm?
When it's narrow it is, like severe MS, then severe the PVH.
So it's basically indirect measurement. If the patient is having severe mitral stenosis, there will be high back pressure or pulmonary venous pressure.
Severe
That
PVH.
leads to the severe pulmonary venous pressures.
Do you think this tricuspid regurgitation is organic?
No, sir, in JVP, Y descent was there.
Hmm?
JVP, Y descent.
So it is a pansystolic
Yes.
murmur, so
You-
likely
You
to.
get organic tricuspid regurgitation without tricuspid stenosis.
Yes, sir.
Yes.
Possible.
You can get.
Yes.
Yes.
But what is the incidence of isolated tricuspid regurgitation? Mitral. I mean, in the mitral stenosis, if there is no tricuspid stenosis, you get an isolated tricuspid regurgitation commonly. The rheumatic heart disease.
Yesterday, it was discussed, no? There was question also, how do we differentiate organic tricuspid regurgitation
So that
from functional tricuspid regurgitation?
so functional TR will pan-systolic, while
Pan-systolic or
organic will be
early
late systolic murmur, sir.
It's the,
मतलब early,
नहीं, early was plate में तो pass और fail के difference है.
early systolic.
Early systolic. Okay, good. One is PA pressure. What are the things can be there?
सर उसमें loud P2 रहेगा अगर patient को
Features of
functional
That types of PH can be
PH
there.
will
You are
be there.
getting everything here.
yes sir.
But still can that be an organic involved?
Yes, superimposed can
Superimpose
be
अगर
It can be, we cannot differentiate, we cannot be sure, but more likely to be functional is likely to be there because other features of pH are there. But what is the proportion of tricuspid involvement in a given case of RH?
The 6% clinically, but autopsy cases like 30 to 40%.
30% is
30 to
the
40%.
level
So
tricuspid.
it's different for different. One is clinical, echo,
And autopsy.
and surgical series, and then autopsy. So all the four are different.
Yes.
Now you said that he has a PND. What is the life history of PND? Patient that gets PND. What happens to these PND attacks as the time goes by?
So as
Do they
the
remain
time
same?
goes,
Do they increase or do they disappear?
so it decreases with the development of second stenosis, with the decreases with the development of right heart failure, and symptoms will improve. Then can be worsened with the heart failure again.
I'm not talking about heart, I'm talking about the PND.
With the severity, if the second stenosis develop, it might be come down.
Do they become more or they become less? Is the
Less.
Less.
What's the mechanism of this? less?
Second stenosis.
So basically what happens because of the chronic fluid accumulation, fluid starts going in the interstitium that loses the air
Redistribution of the body.
redistribution of the body.
What happens to the alveolar?
So there will start alveolar thickening and the fibrosis.
Thickening also occurs.
That
That also prevents the
that also plays.
Development.
And for the completion sake, it's better to say no rheumatic activity.
It's
Just for
no.
completion sake. Yeah, what is the one thing against your diagnosis? What you would have expected that's not there?
So liver dullness. Liver dullness.
Liver enlargement.
Liver enlargement,
Liver dullness.
cardiomegaly. What about cardiomegaly? You're thinking of severe TR that has produced fluid and everything. There is absolutely no cardiomegaly.
Yeah, there should be, now there should be cardiomegaly and liver should be palpable or relieved.
Can this be congenital lemma? Just for the sake of completion.
Symptom wise, no, sir. History is very,
Congenital lemmas by and large never have opening snap. Very
Yes.
rarely they can have, but opening snap is not a feature of congenital lemma. That is how they are.
What should happen to the right border of the heart if there's a severe tricuspid regurgitation?
So it should extend more towards
Huh?
the. Sh-
Should you get some dullness of the right region on
Dull.
the right border? But you said there was nothing on the right side.
in this case was not.
I think there's some odd features that you're describing of the tricuspid regurgitation.
What you want to see first? X-ray or ECG? What will help you more in your diagnosis?
X-rays.
X-ray. Anyway, we decide to show you the ECG first. See. And tell me in the ECG, what is not fitting into your diagnosis? And you have given a diagnosis, rheumatic valvular disease, severe mitral stenosis, severe PVH, severe PH, TR, atrial fibrillation. So what is not keeping with your diagnosis? No RVH in the ECG.
It's all LVH. I didn't see the ECG.
No,
The
they-
DPS is when you put
Yeah,
the
yeah,
ECG.
yeah.
That's what I got.
I also saw very distinct, but there was no.
It's not a right excitation.
What is surprising?
So it's more of regular, but I think it's a flutter with 2:1 block.
Okay.
Uh,
What are the other findings? What were you expecting with your diagnosis?
Expecting, sir,
There is a right axis
axis,
deviation with LA enlargement is there, sir.
LA enlargement.
So it flutter here,
It's a flutter P waves are in between we'll be able to.
flutter 2:1 AV control.
With your diagnosis, what he's asking, with your diagnosis, what you would have expected on ECG,
Right axis deviation, sir.
right axis deviation?
And right ventricular hypertrophy,
Yes,
are they there?
no, sir, RS is less
IVH is
than
not
one.
there, sir.
So how do you explain? There is no right axis, no right ventricular hypertrophy. You are telling atrial fibrillation, there is no atrial fibrillation. That one can understand, there is flutter. Let's be on ECG. So why there is no right axis, no right ventricular hypertrophy?
I think while we are looking at the ECG, but one prominent finding that you have not described this, just go and see the ECG, what is this? Is there anything pulsation? I think the right lobe of liver is enlarged, you are able to treat it there and then.
Like a left
then
ventricular
clearly it goes,
hypertrophy.
somebody, one of
Is
you.
it deep
Pulsation, that's a prominent pulsation. you know.
Predominantly,
Predominantly because
is it a sinus rhythm or what is it? Or is it a flutter wave?
Flutter lag raha hai.
Flutter wave.
So with your so much pulmonary arterial hypertension, should have been a right axis deviation, right ventricle. So you want to change the diagnosis or?
What ventricular chamber is enlargement? Now describe the ECG, let's go back there. Can you go ahead? No, there's an ECG there.
So it's a 12-lead normal standardized ECG. It's a regular reading, but there is no P wave. So atrial flutter with 2:1 block. Axis is around 90 degree.
Why 90 degree? Not exactly 90, na? Like 90 means what should be there, which is not there.
Lead 3.
Equiphasic in one should be there if you are saying 90, it is not there. So then what it is?
Lead one is positive.
Lead one is positive, AVL is negative. So what is the axis?
Right X. Right, more going plus.
AVL is negative and lead one is positive.
Yes.
So that means equiphasic is somewhere in between. So that will be minus 15 equiphasic. So your axis is going to be plus 75. These things you should be very clear at this level.
And there is LVH,
Sorry?
left ventricular enlargement
LVH.
by
What's the criteria that you are
coronal voltage criteria, like V3 is more than 25 for male. It's there.
So can you now explain why there is no RV?
See, I think when you look at the ECG, there's things to start describing what is the rate, what is the rhythm like. You look at the bottom strip, what does it show? It shows an atrial fibrillation or not? Right at the bottom.
Yes, sir, in last
There is a rhythm
irregularities,
strip.
rhythm strip, there is irregularity, RR is changed.
What is it?
AF,
Atrial fibrillation. And what is the axis like?
normal.
Normal. And what about the chamber, ventricular chamber enlargement?
Left ventricular enlargement.
Left ventricular enlargement. Now, does this go against your diagnosis?
No, sir.
It doesn't go against the diagnosis.
No, it goes against the diagnosis, sir. There should be RVH, sir.
Hypertension, tricus, severe tricus regurgitation. You say there is no mitral regurgitation. So how do you explain this left ventricular hypertrophy?
So there should,
There should
like there might be associated
think-
MRs, sir.
Associated MR
Or
could be
can
the possible.
explain this.
So would you like to change now? They say that the systolic and systolic movement that you heard.
Possible.
Two murmurs we can add. One is TR and one is MR
So
murmur.
now you're saying tricus regurgitation and mitral regurgitation both,
Both, sir.
right?
Possible.
Yes.
So why there is a tricus regurgitation when there are no signs of pulmonary abscess on the ECG?
Do you think you might have missed AR in this patient?
AR.
Sir,
It's
there is
possible
no
that,
wide pulse pressure or.
Means BP wise, we measured by oscillometric first of. And that could be like not able to pick up the low
What,
pass.
what happens to signs of AR?
In presence of heart failure, it is masked. As the patient is like crackles in vessel, NYHA class 3, heart failure symptoms can be masked. And in presence of multivalvular disease, like associated can
Now, I'll ask you, you are sitting in your consulting room office. Now you saw the patient, now you saw the ECG. So what diagnosis do you offer?
So I'll think of severe MS with.
Would you like to send him for mitral valvotomy or will you send him for mitral valve replacement?
MVR,
What will you,
replacement,
huh?
replacement.
Replacement?
Yes, sir.
I mean, this is the first thought in your
Like this is
mind.
the first thing I'll think, it
I
is
don't
not for
think
valvular
it
topic.
will be confirmed. Maybe you will do an ECMO and you will do an
Yes,
X-ray.
but predominantly.
Let's see the X-ray.
One more thing is, why there is no RBH? You didn't answer this question, sir. Why there is no RBH on ECG? In other words, what is the sensitivity and specificity of biventricular hypertrophy on ECG? When somebody has LVH, what is the sensitivity specificity of biventricular hypertrophy with ECG?
Say decrease also.
Drastically decreased. So what are the ways to diagnose biventricular hypertrophy in ECG?
ECG, we can get Cat's vessel phenomenon.
That is very rare, only found in children with VLD.
Yes, there can be RVH with left axis
with right
deviation
axis
or
deviation.
LA enlargement features, sir.
So number one is you find features of RBH and LVH in the same ECG,
Yes.
which is uncommon. And second one is, as you say, axis versus LVH with
Axis
right
versus-
axis. It's almost rightward axis in this case also.
Yes, sir.
So, but because these two cancel out each other, the electrical forces cancel out each other at times. That is why you don't find often RBH when you have such significant LVH.
Okay, I'll ask you one question. You heard the first sound to be very loud, right? Can this be explained by his body stature? That man is very thin chest, wall. You can see his ribs are big thin. There's no muscle. Muscle seen on his chest. Did you look for any thyrotoxicosis?
So as if there is no thyroid, means thyroid enlargement is not there.
No, but at least looking at his chest.
I don't.
Could be
explain on the basis of
emaciated, yes,
rather than a
can be.
valvular pathology.
So it can be.
Because now once you got left ventricular hypertrophy, you've got to go back on your diagnosis.
Either MR or both, what you want to put your money on.
MR, sir.
Clinically, there is no features of it.
What happens to the first sound in the patient who has got a significant
It's soft, sir.
It's soft.
Yes.
So it is according to loud. On that count, and plus what happens to the pulse pressure?
There'll be wide pulse
Wide
pressure.
pulse
Right, what is the pulse pressure?
So it is only 30.
Normal,
Malab.
So at least on that you can rule out the clinically you can rule out significant.
Significant AR we can rule out.
Most of the severe AR is not there, but we would easily list a moderate AR number because
Yes.
the heart rates are almost 125 now.
Yes, sir.
So we could easily miss a AR number if it is there only.
Chest X-ray.
And
Yes, sir.
It-
Chest X-ray peer view, showing there is a massive pleural effusion on the right side. Still, heart is well centered, it's not shifted. And there is a difficult to say.
So there is no evidence of any cardiomegaly with mild
LPA
PH.
So because of this massive pleural effusion, you won't be able to comment on many things. So that's what you should say. That first I'd like to tap this pleural effusion and see an X-ray after tapping. Then you can get some other signs, which you are looking for. Now that will be the limitation of this X-ray.
Is it threatening of left heart border?
Straightening, so it is. There is not.
But what about I say there is collapse because of massive pleural effusion and then there is a shift of the heart towards the left side. But there is cardiomegaly. What is against that argument?
Okay.
So that
Yes,
trachea
because
should be
there is so
pushed
much of
toward-
pleural effusion, you don't expect the heart to be pulled.
Hard to be pulled there.
the trachea is in the center, right?
Central,
Yes, take it in central position.
What about PVH? What about PAH?
CVS, PVH,
So it's difficult to
What
put
is the evidence for severe PVH?
pleural effusion. Pleural effusion.
Difficult to comment on this, sir, but
Difficult to comment.
comment.
So what are the phase two grade, PVH and
So in
PVH
PVH,
cephalization is the grade one, then grade two is the curly B lines. Then grade three, we can get fissural edema and
bad wing operation.
Bad wing operation.
Bad wing operation.
what about PH?
PH like here's a pulmonary artery enlargement, not that.
So in mild dilatation of the pulmonary artery can be appreciated on the left side. So left
No, it is actually significant. Like
Ah,
you don't
this-
get, you don't get left pulmonary artery dilatation like this.
Yes, sir, there's
Like
significant
really-
dilatation of the left pulmonary artery. sir.
Clearly dilated.
Yes. With mild peripheral pruning.
Anyway, I think, what I would suggest, we should rewrite your
I think I
diagnosis.
need to echo report.
Sure. Echo, yeah.
They just say severe MS, moderate MR, mild AS with moderate AR, moderate ER with moderate PH. With global early hyperkinesia, with severe early systolic dysfunction. With MBA of 1, ejection fraction. Active valve gradient of 27. Mean maternal gradient of 27 by ED of 30. And ejection fraction of 32% with a TAPC of 1.7. So moderate AR resistance is there. You can active valve injury. So moderate MR and moderate AR.
I think these two explain the ECG.
ECG, LV enlargement.
Okay, I think. Very good.
Same with what I was telling yesterday in my talk of multivalvular disease, that in those patients of mitral stenosis, where there is pulmonary hypertension, cardiac output has fallen, there may be, you can miss some signs of aortic regurgitation. So when such a question is asked at this stage, you should at least be open that it is possible that these signs would have been missed. The other thing which you can say is that I like to further make this patient out of heart failure and then reassess the
Again,
clinical
reassess.
signs. Many times the clinical signs appear when the heart failure has been treated. So these are the important lessons. And again, as Sir was asking you, the difference between TR and MR. In such a situation, when patient has been such a heart failure, the chances of a mixed mitral lesion is there. So you should be open and look at it. Look about it.
I think one of them done very well.
And
Yeah,
also, I would feel that in presence of the massive fluid effusion, we certainly mask all the signs.
Yes, sir.
and they will certainly alter the sign. And plus, I think what you were getting first from the love is because it's thin chest wall,
Yes.
and that's why you're feeling. Also, I think
LV
it was
dysfunction
proper
also,
recording.
LV dysfunction
Right,
also,
was it
it
right?
must have been
That
rapid
created
rate he has
effort,
come.
but,
Mm.
Second is.
Could you explain a little bit?
I think
There was a left ventricular pathology that one had to explain.
both of them done very well, so give them a big hand.
Very good.
Really, really lot of stress to stand in front of everybody, expose yourself. Very good, well done. Hard question, are you passing them or good? Passing them is distinction. Oh, great, thank you.
No, sir.
Yes, sir. ECG and X-ray was totally different.
ECG was different, so, yeah. Yes. It was difficult.
You were very categorical, there was no MR at all. Both of you were very strong on PR, why you good at that moment. But subsequently,
It was.
there are really some examiners not at all. Anyway, thank you. Moving on the second case, it's a named as short case, but of course it will depend on the examiners. So I request, this will be the Umarvelu and the other gentleman. Manohar. These two candidates of present them the next case. Are they there? Yeah, while we are waiting, so how do you assess the ventricular function in RSV case? So this patient had 30%, we didn't comment on it. But what are the ways to assess LV function in an RSV case? So some rules are there, like for example, it's very difficult to assess clinically. But if we find a Bisperian pulse, that means almost always the LV function is normal. Such rapid ejection has to be there to produce a Bisperian pulse. That means generally, by and large, LV function is normal. As he is trying to point out, you find a dilated apical impulse. You find, for example, MR or AR. You expect the apex to be dilated, but instead you start finding heaving nature of apex. That indicates likely the LV is starting to fail. So in other words, a dilated apex where you want dilated apex to be heard, you start feeling heaving apical impulse, then you should think of LV dyspnea. And the reverse is also true. You find a AS is there, patient with AS, you want to have a heaving apical impulse in the right place, in the correct place. If you start finding a dilated apex, that situation, and you start diffuse apical impulse found in a heaving apical impulse situation, you should start thinking of the LV dyspnea. And the proportional pulse pressure. What is proportional pulse pressure? So I think you should read about that, like pulse pressure.
Okay, good. So moving on the second case, our examiners would be Dr. B. Srinivas, he's actually for Nizams, and I'll ask Rama again to be there. Can you be there? And then Dr. Allegation. And the presenters, as I said, there's Manohar and Kumar. The time assigned is 35 minutes.
Please introduce yourself.
President from Sri Jayadeva Institute of Cardiovascular.
I'm Dr. Kumaravel, final year PG from Chengalpattu Medical College.
Yeah, you may start. So this is a short case. So what I was told is that first you will give a brief history and details of your clinical examination. So brief history now.
Yes. So my patient is of a 49 years old female patient who came from Markaspur, came with chief complaints of her predominant complaints were breathlessness of NIH class 2 since 2 years. And there is a 1 month ago, she had a sudden onset of cough along with a chest pain, and she admitted in a local hospital where they were evaluated, and she has been prescribed medication followed by her symptoms were subsided. And the chest pain is of typical anginal type of, which was of a retrosternal, and which was a chest pain, and it's like more of an sudden onset chest pain. And it was been relieved with the medication which is given in the hospital, and she needed an emergency hospitalization at that time. Yes, sir. A 14 years old male patient came with the chief complaints of breathlessness of NIH class 2 since 2 years, with a sudden onset of chest pain 1 month ago, and which made her hospitalization, and the pain relieved followed by medication, and the pain characters of a typical anginal pain. And present her, she was in a NIH class 2, she restricted her activities, and she was on oral medication.
Do you think the chest pain is suggestive of angina? Typical or atypical or non-anginal?
Typical anginal pain, sir.
How do you say that?
The pain was more of a retrosternal, and the pain was at the time she was sudden in onset, and it was radiating to the left arm.
What are the 3 criteria to say it's a typical angina?
Sir?
3 points to say that
character, site, aggravating and relieving factors.
That is asking about 3 classical features to describe typical, atypical, and non-cardiac.
Site, character of the pain, site, and aggravating and relieving factors.
So site agreed. Then the second point is?
Character of the...
Okay. So when do you say typical angina? When do you say atypical angina? When do you say non-anginal chest pain?
Sir, these three features of the,
All the three are there in this typical. What are the
Yes.
three features? One site is they agreed. What else?
Aggravating, second factor, third factor, relieving factor.
It should be on exertion. Was
Exertion.
it on exertion? Like,
no, sir, she had a sudden onset associated with the drenching sweats and all, and followed by, she was,
so,
Okay.
so you, what should be your answer to sir's question is most of these three features are for chronic stable angina.
Yes, chronic.
They are exertional angina.
exertional.
So if you use this classification, all your unstable angina MI will be different.
Yes.
So we cannot use this classification there. It
Sure.
has to be only exertional chest pain, then
Yes.
we can use this. But is it MI? Like, are we dealing with a case of MI?
Sir, what she was given of any, history
What
wise,
are the typical angina and what is the difference between typical angina and MI chest pain? Like a classical MI,
sir, sudden in onset,
both will be sudden in onset. Okay.
Severity, severity and duration
duration,
and severity.
severity,
Severity, duration and associated factors.
factors.
So what are the typical duration of an MI chest pain?
As the time progresses, the
Pain will
pain,
reduce.
severity of pain increases.
No, but what is the duration of chest pain in an MI compared to an anginal episode? In an MI, acute MI, what is the duration of chest pain?
More than 30 minutes.
Generally, it is more prolonged. Whereas an anginal episode generally
It will
short
be
lasting.
short.
So less than 10 minutes in
10
general.
minutes.
So what about associated factors like?
The sweating with the, sympathetic activity stimulations like
Sweating,
sweating, taking,
vomiting,
yes,
all those
vomiting
things
and
will be there.
giddiness.
What are the other conditions which produce anginal type of chest pain without, apart from the myocardial?
Sir, non-associated causes of CAD like, in aortic stenosis, there is a supply-demand mismatch. In ischemia of RV ischemia, if it is of IPH, pulmonary artery hypertension, or sir, HOCM with an myocardial bridging type.
So no,
What are the other structural heart disease?
Aortic
That can go with
dissection.
anginal episode.
Aortic
Aortic
dissection, which is of typical of backside pain. And
so this 49-year-old female patient has come with breathlessness on exertion for 2 or 3 years and
Yes.
then sudden onset retrosternal chest pain. So how do you approach this symptomatology?
sir, whatever the patient is having an established cardiac heart disease, from if based on the history for 2 years, and one precipitating factor has aggravated her on the day of admission, which made her hospitalized on the day. Like,
So what are the possible cardiac causes for an exertional breathlessness in a middle-aged female? Assuming it's a cardiac disease, what could be the possibilities?
sir, most of the physiological things like anemia could be,
You said, assuming it's cardiac.
okay,
So leave alone non-cardiac and other medical conditions. So what are the cardiac causes of dyspnea on exertion in a 49-year-old female?
sir, most
some
common
chest pain.
valvular heart disease of the left side, like mitral stenosis could be there. Of an LVOT obstruction.
How do you explain retrosternal chest pain in mitral stenosis?
Sir, PH causing the RV ischemia.
How often do you see that in an MS patient? So theoretically it can. How often in?
Percentage like this, like sudden onset chest pain. How often you say? Almost never.
So now this leads to the question, do you attach any importance to the retrosternal chest pain as a part of the symptoms of the cardiac lesion, or is it unrelated to that? That also is another question you have to consider. Okay, because if you are unable to fit that into your overall approach to the problem, then you might like to disregard that. Okay, one is mitral stenosis you want to consider. So what is in favor of mitral stenosis and against mitral stenosis with this?
Sir, there is no PND or orthopnea episodes which is saying of no palpitations history which not there.
But it is there, it would maybe consideration of MS will be much more stronger, but the absence doesn't exclude the consideration.
Preload condition like fatigue and all.
Why do you expect fatigue in an MS patient? When does the patient with mitral stenosis get fatigue or exertional fatigue?
Once the pH get established.
When the patient goes into low output state due to right heart failure, there's an advanced state of mitral stenosis. Otherwise, the fatigue is not an important symptom of mitral stenosis. Okay. Still, okay, in India, you might try to consider mitral stenosis. Anything else?
Even on your exam, suppose if you are sitting in the OPD, a 50-year-old female comes with chest pain, predominantly chest pain and some dyspnea before. Do you want to keep MS as your first possibility? No, sir. So why do the part of the other possibility? That's what I was asking. Be realistic also.
CAD, coronary artery disease to the.
Why
ischemic
dyspnea and CAD?
Sir?
Why dyspnea and CAD?
Angina equivalent symptoms.
One, what are the other causes of dyspnea and CAD?
Sir, established LV diastolic dysfunction.
Or
Sir,
systolic dysfunction. What is the
Systolic.
systolic?
Ischemic cardiomyopathy? Hmm?
ischemic cardiomyopathy.
Then what else? One, whenever there is ischemia happens, diastolic dysfunction happens, the patient can have heart failure. Okay. Diastolic function.
So diastolic dysfunction followed
It's
by.
already giving you a hint.
So the first thing is of a progressive event like if a diastolic dysfunction followed by systolic dysfunction and the patient's just of a so percent of the myocardium involved if it is more
No,
than
no, no, we are not asking about that. So diastolic dysfunction first agreed, then systolic, then what will happen to filling pressures? Elevation of filling
elevated
pressures.
will be
Then ECG changes, then angina. You understand that? So angina is the last thing to occur after the ischemia occurs. Okay, anything else you want to consider? At least 3 differential diagnoses you give briefly, then we'll move on to the examination.
Sir, in this LRA, this mitral valve prolapse with MR could be.
If you are thinking of previous angina, then give the differentials of angina. If you are thinking of atypical chest pain, then you think of MVP and various other things and all those things. But if you are clearly categorical that this is anginal chest pain, retrosternal pain, then give those things up first.
That is what I first told you. So how do you want to treat that chest pain? Do you want to give importance to it or do you want to ignore it?
Sir, the chest pain was exacerbated with the cough and breathlessness. So it could be an misleading factor for me.
Can this be IPH?
Sir?
Can this be IPH?
Sir, IPH, the
3-year
patient.
dyspnea, 14-year-old female, comes to you now with chest pain and developing dyspnea with some chest pain.
Sir, but there is no progress history of fatigue or patient low cardiac output state from the last 2 years.
And you expect all the IPH to be like that. 3 years is not a big time in IPH. Can this be BPH, IPH?
No, why do you want fatigue to be an important symptom in every lesion? That's what you said, even in mitral stenosis, fatigue. So don't be obsessed with one particular symptom. And sir is suggesting in a female patient, middle age, presenting with some 3-4 years of breathlessness on exertion, with no history of orthopnea or PND, ruling out perhaps a left heart, significant left heart disease, you might as well consider a right heart disease like a pulmonary hypertension.
Angina is significant, you want to keep hypertension as a possibility.
Sir, there is no family history suggest of any.
Okay, then you tell what do you want to consider?
Palpitations.
You see, whatever suggestions we are offering to you, you are negating. So no, to tell us what do you want to consider? One is mitral stenosis, he said, with a little pinch of salt, we have accepted that. But I want 2 more differential diagnoses.
The pH could be.
That's what I'm suggesting. You negated it and now you want to.
PAH syndrome, it could be idiopathic or something else. Okay, PAH syndrome, right? Then
Ischemic heart disease, you should keep first in a 50 years old in India today. Ischemic heart disease, possibly before even MS. If you think that is serious angina, and that episode is a
no, just give on your own one differential diagnosis, which is convincing here. Sir is not going to suggest. You may suggest. Kumarvelu, huh? What is your name?
So oftentimes you must be wondering why we are all repeatedly banking on this. Like, what is the importance of this? Is we are trying to understand whether you understand the natural history of all this and whether you are able to apply it in a particular given. That is the primary purpose of a clinician.
Could you-
Whatever you do, whether you are able to apply the knowledge that you have.
Could you consider dilated cardiomyopathy with this history? It's not necessary always that they should have presented with, frank heart failure. Huh? Early stages where there is no LV dilatation with some LV dysfunction, there can be exertional breathlessness only without right heart failure or no biventricular failure. So you may consider that early stages of dilated cardiomyopathy. Sir. So summarizing the historical considerations, mitral stenosis, sir has suggested ischemic cardiomyopathy, pulmonary hypertension, and dilated cardiomyopathy. HOC.
There's nothing against HOC in that.
Restrictive cardiomyopathy would you consider?
So there are no predominant right heart failure symptoms, patient presentation.
So what is predominant involvement, incidence of predominant involvement of left heart in
LV filling pressures, which is causing of this.
what is the incidence? Left heart alone is involved in endomyocardial fibrosis. Left heart involvement, right heart involvement, biventricular involvement. What is the relative incidences in India?
Predominantly the right side is the left side is. Or biventricular.
Cardiomyopathy. Restrictive.
Restrictive endomyocardial fibrosis we are talking about.
Predominantly, RV type is more. Right ventricular type is more common than left.
Biventricular, right ventricular type is more common.
Biventricular is more common. Okay. Go to the exam.
Salient findings in the exam.
Yes. Sir, on physical examination, the patient is conscious, coherent, well-oriented, and the pulse rate was 80 per minute. The blood pressure of the right upper limb and lower limbs were 120 by 90. And the pulse is regular, sir, normal volume, no radioradial delay. Sorry, sir, there is a radioradial delay and there is no radiofemoral delay. And the saturation of the right upper limb, this was 88.
You have a radial delay, what is there? What are the other pulses?
Sir, no radiofemoral delay was appreciated from. Yes, sir, left radial is more well palpable, sir.
What is the BP difference? Just take one blood pressure.
Sir,
radial delay. You have to give all the 4 blood pressure.
Sir, yes, sir. We are giving the right upper limb brachial artery pulse pressures were 120/90. On the left, it is 120/80, which was.
Where is the question of delay then?
Sir?
So when do you get delay? Is can delay occur in isolation without any effect on the volume or strength of the pulse?
Sir, it's like more of an iatrogenic cause in the hospital because no, sir, but the pulse when compared to other pulse is very few.
What about right brachial?
Brachial is good, sir. Right brachial is good.
Because once you say radial delay, then we think of some other disease. Yes, undergone a procedure also.
He was not giving an history, sir, but they're taking some samples were taken from this and could be an ABG.
Okay, continue.
Sir, the saturation of the right upper limb, it was 88%, sir, on room air.
88%?
Yes, sir.
Left
is also same.
All the 4 limbs are 88%.
Yes.
Addressed.
Yes, sir.
Exercise?
Lower limb, sir, will now 90 it is coming, sir. Sir. The remaining, there is no clubbing or cyanosis or palar or ictus were appreciated, sir.
No clubbing or cyanosis.
So no, sir, we can't have luxury.
Is there exertional cyanosis occurring?
Sir, we didn't made her exertion, sir.
You didn't make.
We didn't.
Would you have done? Would you have liked to do?
Sir, resting saturation was 88%. So By exercise.
Then why is she not cyanosed? So what is an early sign of cyanosis? Intermittent right to left shunt, let us say, assuming it's a right to left shunt across a shunt lesion. If there is no frank cyanosis and saturation is something like that, what would you look for very meticulously? What's called as a tuft erythema in the fingernails. So tuft erythema suggests intermittent right to left shunt occurring. Okay.
And sir, in general physical examination, only we can appreciate this much, sir. Can I go to the systemic examination? General physical, yes. On systemic examination, inspection and palpation, the apical impulse is not. Sorry, sir. Sir, JVP, there is normal JVP, sir, with a normal waveforms were visualized. Sir, it was on sitting, it was not seen. So it looks like
No,
normal.
do you look for the JVP mean column always in a sitting up position? Or?
Sir, if in sitting, if the JVP is visualized, it implies that it's an elevated JVP. Then I can make it on a 45 degrees and to measure the JVP.
It is a little convoluted way of looking at the JVP. You try to do in a systematic way as traditionally it is recommended or advised. So let the patient recline, keep the patient in a recline in 45 degrees and then look for the JVP. If 45 degrees recline, if you are not able to see the upper column, then you make the patient sit up and see for the upper column. Okay.
What about the waveform? How do you look at the waveform? Even at 45, you're not able to see the waveform. Then how did you look at the waveform in this particular? That's what you're saying. 45 also is not. So how did you think that this waveforms are normal? Make her lie down? Lie. Then can you tell what is the limit of the column? Well, the height of the JVP. You are able to see lying down.
Yes, sir, we can see. But it's more like of a normal waveforms, looks like, so there's no problem.
Somewhere it is seen, so we can you report the height?
Sir, it was around the mid of the stairs.
Don't get into the trap. So you cannot
comment
on the height of the JVP when the patient is made to lie down flat. So this is one column, one straight column. You cannot measure the height. So it can be used to diagnose the waveforms of JVP, identify the waveforms of JVP, but you cannot report the height of JVP when the patient is made to lie down flat. Same thing like apical impulse, if you are not finding it, then make the patient to left side of the position, find the character of apical impulse, but you cannot use it for the position of apical impulse. These things are basic things.
So please again, clearly tell your examination findings of JVP.
Sir?
JVP, please tell again.
Sir, the JVP was normal, sir, with normal waveforms were visualized and which were
Whenever you speak of JVP, there are two components to JVP. One is the mean column height or pressure component. P means pressure, as well as pulse amplitude or pulse wave pattern. So you should tell about both. How is the JVP mean column height, which you said in straight 90 degrees upright position, it is normal. It's okay. Then how is the waveform? It is normal. Normal means A is more than V. A is normally more than V, is abnormally more.
It's like normal more than is not an abnormal wave, A wave type of.
It's not a giant A wave.
Don't get into the solve trap. The stuck only is try to take it to the case that JVP is not important. So remember, if you are able to tell JVP in fashion like normal waveform, the height of JVP and respective area, generally you would have moved on. One.
Sir, on inspection and palpation on the cardiovascular system examination, so the apical not well localized. On left lateral position, we can't able to see, characterize the apical impulse. It is more type. And there is a palpable P2 on the second intercostal space.
Palpable D.
Grade 2 parasternal lead with palpable P2. Sir, on epigastric pulsations, the RV pulsations can be felt, sir, at the tip of my thumb, which is of more of an RV pulsations. Sir, no, please.
So how do you know it is RV apex? Why is it not an LV apex?
Sir, it is not well localized, characterized, and the second thing, the heave, whatever I felt, it's somewhat synchronizing with the apex on the side, sir.
I think maybe when we would have discussed all this, but it has been 3-4 points for an RV of LV example.
Sir,
What are those points?
it's a localized of a LV with a medial retraction, it will be in LV,
That's a very important thing that we should.
medial retraction, and
You will have lateral retraction if it is in a RV apex. Diffuse in nature. So if you have RV enlargement suggested by left parasternal pulsations and also a localized LV impulse at the apex, what else will be there?
RV,
You have an RV enlargement suggested by left parasternal, not in this patient, left parasternal pulsation, and an LV impulse in the apex. What will be there between the two? There will be a
LA pulsations.
LV. Apical LV pulsation and left parasternal pulsations of RV. You will have a retraction between the two.
Retraction.
So in other words, for the sake of everybody, like how to differentiate between LV and RV? LV effect is generally very localized. It's a ping-pong ball coming in between two ribs. Right? Whereas RV effect is generally a diffuse apical impulse covering more than two, and then medial versus lateral retraction is there. And then most important thing is that I think we just become cardiologist, we just forgot undergraduate. First and foremost point is lateral versus down and out.
Down and out. Okay.
LV is down and out, whereas RV will be lateral distal. That should be your first point. The fourth point is whether it is continuous with your
Parasternal.
These are the 4 points generally considered between LV and RV apical impulse.
Okay.
So that's sir, percussion, the second space of the left side is dull, sir, dull node, and the cardiac borders were local.
Here, I think infantile permeation is important. In this case, it's important because there is cyanosis. Whether it is situs solidus or not.
Yes, situs was normal, sir.
Start with that. So, situs, liver, and then go to your system.
Sir, on dulls. Sir, on auscultation, the S1 was well heard. S2, there is a wide split. S1 is normal. S1 is normal. S2 is wide split was there heard, sir. Wide fixed split is there. Yes. With an P2 component of the split was loud, sir.
Loud means is it more than A2?
Yes, sir, it's more than A2.
Is more than A2 given at apex?
Yes, sir.
Very important.
Yes.
Why is it?
Sir, in pulmonary artery hypertension.
Yeah, I know. So how do you grade clinically the severity of pulmonary artery hypertension based on the relative intensity of A2 and P2?
Sir, if the P2 was loud, it's okay, and palpable, the pulmonary artery systolic pressures will be more than 50, is one of the proved findings.
No, my question is about relative intensity of A2 and P2.
Sir, generally the P2 will not be heard at the apex. If it is heard, it is of equal intensity of A2 and P2.
Okay. If the P2, even in pulmonary area, normally A2 is louder than P2. If P2 is equal to A2 in pulmonary area, it is, you can say it's a mild pulmonary artery hypertension. If P2 is more than A2 in intensity at pulmonary area only, it is a moderate pulmonary hypertension. If P2 is banging in intensity and louder than A2 even at apex and other areas, it is severe pulmonary artery hypertension. So how is it here?
Sir, here it is heard at the apex, sir, and it is palpable.
It's a question is about the relative intensity.
Severe.
So it is more than A2 even at apex. Okay.
Sir, there is an systolic murmur which is heard at the right. What?
This is not the way to describe it. Please. Huh?
There is a pansystolic murmur which was heard at the left fourth intercostal space. Which
See,
is
there are a lot of adjectives you have to add before saying pansystolic about its pitch, its intensity, its grade, and all that should have been described before saying pansystolic murmur. Okay. Now again repeat.
pansystolic murmur of with a high pitched murmur, which is often heard at the left fourth intercostal space, which is more heard on the deep inspiration, and it's of a grade 3/6 murmur. It's a common trap that everybody falls into. Suppose if you are looking for an inspirator release, would you ask the patient to do deep inspiration? No, normal inspiration. Why are you saying that this is more heard on deep inspiration? But why are you doing it in AR? AR is the one situation that we always used it to do in end expiration, ask the patient to help the breath in end expiration. Rest of all the movements are always in normal breathing. Rest of all the variation that we look at is normal breathing. Why we do it in that fashion in AR? That is the only situation where we ask them to do help the breath in expiration and then ask them to. Why do we do that? There are two reasons for that. Generally, the AR murmur, the frequency and the pitch of the murmur and the character of the murmur correlates with the respiratory sounds. You can get confused. And then while doing that, you remove the lobe of the lung that comes between your chest wall and the heart. So you just remove it while breathing in. That's why we do that. Rest of all is normal respiration. Never changes in deep inspiration with that.
So is this increasing on inspiration?
Yes.
Okay. So high-pitched pansystolic murmur occurring at left lower sternal border, increasing on inspiration. Okay. Anything else on auscultation?
Sir, one additional sound I can heard, sir, it is of a additional heart clicks type sound because I can't.
No. Yeah,
Click, which click, click, click.
sir, let him say, you are giving all the clues. That is very generous. Tell me, what is that additional sound? No, whatever you feel, please fearlessly say this.
Sir, I've heard an additional sound after S2, which is of a vascular type of pulmonary hypertension click.
Where?
In the second and
No, in cardiac cycle, where is it occurring?
Sir, after sir,
After
S1.
After S1.
Yes.
So you say is it constant or inconstant?
Sir, it's an inconstant click, sir.
Inconstant click, ejection click.
It's a non-phasic click, sir. I mean, sorry, it's a
No,
constant.
the only way you describe a click is whether it is constant or inconstant. Don't use that non-phasic, etc. So it's an inconstant click or constant click?
Constant click.
Constant ejection click.
Yeah.
You have heard. Good, very good. Okay. Anything else? Is there any Graham-Steele murmur? You should look for that. Yeah. RVOT murmur is there?
Don't appreciate.
Couldn't appreciate.
What is the diagnosis? Other systems are normal. Yes, sir. Other systems are
Give a systematic diagnosis.
Sir, this is of a congenital heart disease. With sir,
Cyanotic or acyanotic?
congenital heart disease. Cyanotic congenital heart disease, which is of a probably of atrial septal defect, with of a predominantly.
Before that, you should say the broad group. Is it Eisenmenger syndrome or not?
Then Eisenmenger is
So tell Eisenmenger syndrome. Then you say where is the level of the shunt, right to left shunt.
right with PA with suppress.
So cyanotic congenital heart disease, Eisenmenger syndrome, ASD. Okay. Then continue. Is there right heart failure? No.
It's a class 2 symptoms as of now.
Is there right heart failure?
No, sir, no predominant congestive cardiac failure.
We should not be asking this.
So no congestive cardiac failure symptoms were there, sir. And there is no, sir, rhythm was sinus rhythm with no any
No evidence of infective endocarditis.
endocarditis or embolic manifestation.
Not substantiate each component of your diagnosis from your own examination finding.
So first of all, it is often a patient is having a congenital heart disease, which is probable first diagnosed is in the point of like the patient was apparent of didn't have any symptoms from the last of her life. Presentation was of a
No, it's very simple. No, patient has desaturation and
Desaturation.
some cyanosis. So
desaturation.
it's a cyanotic congenital heart disease. Okay, then why do you say it is a right to left shunt across ASD? Why is it not something else? VSD Eisenmenger or PD
Sir,
Eisenmenger?
the P2, the
Before that, DPHD, it is decreased.
sir, it is a decreased QP ratio. Decreased QP. And the things were favoring of ASD is of a wide fixed split. FFA, the thing is VSD, it would be in single. And the second is point is sir, cardiomegaly is not very sure of this. The age of the patient. Sir, age of the patient is of 40 years. It is of ASD with Eisenmenger most. What about PR? Like have no PR? Sir, ASD is more like age to have PR.
But in other words, how do you diagnose PH in ASD?
Sir?
Liver on this patient, how do you diagnose PH in ASD?
The split which will be wide variable, now it will be in wide fixed.
If you keep on after telling every 3 months, 6 months, note it down, then you can say that. But otherwise, it will remain wide and fixed.
Sir, the cardiomegaly which will be regress. No, cardiomegaly will be appreciated in ASD. With,
No, before pulmonary artery hypertension develops, is it a wide variable split in ASD?
yes, sir. No, no, sir.
What is it?
That is wide fixed split in ASD.
Wide fixed.
It's always wide fixed split. That is the
wide-
pathognomonic clinical sign, whether it is PAH or no PAH.
So how do you diagnose PH in ASD?
So the desaturation level.
One is desaturation. Then if there is desaturation, then it could be there. Is P2 loud in ASD alone can happen without the PH?
Yes, sir, it can happen. So the
Can P2 be palpable in ASD without the PH?
yes, sir, it can.
Can the left parasternal be there in ASD without PH?
Yes, sir, volume over.
So what you have to understand is all these signs of PH can be there in isolated ASD with large flow also. What will be missing is either patient is cyanosis, then you can think of Eisenmenger, or all the features of a large ASD, large tank, but doesn't have a flow murmur. It doesn't have an RPS. That means all this is happening because of PA pressure rather than decreased PA pressure rather than increased flow. So all these things happen because of two reasons can happen in ASD. If the flow is very large, then you can have parasternal heat, you can have a loud murmur at the base of the heart, and you can have a palpable flow. All those things can be there. But if it is flow, because of flow, you should get an RBS3, you should get a good murmur there, MDM there. If you're not getting them in the presence of RBS3, a large heart, a large ASD, then you should think of PH. So PH diagnosis is difficult in ASD, but in this case, you have obviously cyanosis.
So is PAH is due to two reasons. One is PAH related to flow, as far as been telling. The other one is PAH due to elevation of the pulmonary vascular resistance. The PAH is due to large flow, as he already told. There will be RVS3 and a tricuspid flow rumble, tricuspid MDM, and an RVOT flow murmur also, ejection systolic murmur. When PAH is due to increase in pulmonary vascular resistance, flow will be curtailed. So these symptoms of large flow, these fine signs of large flow like RVS3, tricuspid MDM, and RVOT murmur will disappear. So that's how so PAH can occur with flow itself. So that is a reversible situation. You can close it either by device or by surgery. But when the patient develops pulmonary PAH due to raised PVR, you have to look for the operability. Okay, now what is the incidence of Eisenmengerization in ASD depending upon the age?
Sir, followed series, it is of more than 35 years, the Eisenmenger. And
More than 35 years?
Eisenmengerization, Eisenmenger will manifest of ASD.
No, that is, I'm not saying what is the mean age at which ASD Eisenmenger is clinically diagnosed. That's what Paul Wood says. That's not the occurrence. Occurrence usually in the elderly, adult age only. But first decade of life, what is the incidence? Second decade of life, what is the incidence? After 40 years, what is the incidence?
Sir, in first half of life, the ASD Eisenmenger will not be able to isolated ASD until unless the association with on.
So it's very less than, so so there is EMC series by Cherian et al. So in first decade, it is about 6%. Second decade, it is about 7% only. And after 40 years, there is a sharp increase in incidence of pulmonary arterial hypertension, atrial arrhythmias, etc. Okay. So it will be those who are destined to become Eisenmenger ASD, 90% of them will develop a Eisenmengerization in adult life, like fourth decade. Okay. Same findings, cyanosis, let us say patient had cyanosis and clubbing with clinical findings of ASD, like widespread second sound.
Could be common atrium condition or coronary sinus defect. This will be early unrouged coronary sinus and rare case of TAPS.
But what is the future in the TAP that you are not getting?
Sir, increased flow conditions
So
of
like that will be find RBSD, MDM, flow mobility, all those things will be there and
Just tell me all the causes of cyanosis associated with clinical features of ASD,
Sir,
not in this age, right from the neonatal or infancy to adult age.
Sir, ASD with TR could be the and eustachian.
Why ASD is here?
So the jet which is related to TPFO.
That's the last thing I should say. What are the other previously you have to say, like for example, one most important thing is ASD with PS or ASD with PA.
Yes.
These two are done. So what are the other things that can be associated with cyanosis?
Sir, the IVC blood which is directing the
Yeah,
eustachian valve.
yeah,
from-
yeah.
What is that known as?
Sir,
What is the condition which they present with? What the arthro some syndrome is there? How do they present in cyanosis? What is the typical feature of cyanosis?
Sir, reverse differential cyanosis.
Not reverse.
No,
What is the arthrodysplasia? Platypnea.
sir, platypnea arthritis. Yes.
That's one. Then what else?
So transient neonatal cyanosis of infants or newborn with ASD. So because of high PVR, there can be right to left shunt across the ASD, and that will cause that. Then orthodeoxia platypnea, then Eisenmenger.
This is large question is asked. We have unroofed coronary sinus.
Ragib syndrome. Huh?
Or
Okay.
we can have Epstein's anomaly.
Epstein's anomaly.
Or RE hypoplasia, because there could be RE problems can be there that can produce canting. And then you can have sometimes the eustachian valve directing the flow that you already uncommoned.
And then ASD is a part of a complex congenital heart disease like tricuspid atresia. Okay, like that. So at least 10 causes you have to learn TAPVC.
And you finish with the diagnosis. What is the echo wise? Just pain.
Sir, one possibility is of the sir, what it could be an RV ischemia could be which is echo finding.
Okay, echo diagnosis, please.
The echo says titus solidus, levocardia, 2 atria, 2 ventricles, intact ventricular septum, large ostium segment ASD with bidirectional shunt, with moderate ER with severe PH, mean PA pressure of 50.
So one last question. When you have clinically auscultable TR murmur and echo also showing significant TR, why is your JVP normal? Why VVAV is at least not equal to A, if not more?
Because of the roomy RA which is
See, your JVP examination, I think, is not very accurate.
What do you want to do for her?
sir, operability
Want
cats.
to test for upper?
Yes,
Want to do a cardiac imaging?
yes, yes.
Why somebody is 80 saturated? Why you want to test for operability?
At rest, it is 88%.
With 88%, there is no way you should be doing thundership or some other cause of cyanosis that we discussed. But because of PA pressure, 88, I don't think we should be taken. Well, how do you want to treat her?
Sir, the pH reduction, there is a calcium channel blockers. With
Calcium
no,
channel
no, sir. Like endothelial is a prosentan and direct
Which one will you prefer, combination therapy or single therapy?
combination therapy.
Why? Why combination nitrogen syndrome? What is the evidence for combination therapy in nitrogen syndrome? What is the evidence of combination therapy in IPA? Absolutely. Right. तुम लोग तो बहुत ambitious रहते हो. Ambition trial. So such trials are not available in nitrogen syndrome. So some of the combination studies were negative. So you may not start in everybody with combination. So which drug will you prefer?
Phosphodiesterase 5 inhibitors.
Maybe bosentan has most evidence. So people generally prefer bosentan in nitrogen, but you can use any of them. Either two of, if the patient is sick, then you can try combination. Otherwise, you can start with ERAs and then add PG.
I think we'll stop. Okay, okay. Okay, thank you. They have done very well. Give them a big hand.
Thank you. So moving on, because we are really running out of the time. We have the last case, only for 30 minutes. I request of the last case, please come on last.
So please start straight away. Give briefly your history, like the previous candidate, and your examination findings.
Good afternoon. I am presenting a case of 54-year-old male patient working as a railway officer, presented with chief complaint of palpitation since 10 years and dyspnea on exertion since 10 years. Patient,
Go a little slow, please. Go a little slow.
yeah. Okay. So chief complaint is palpitation since 10 years and dyspnea on exertion since 10 years. History of present illness. Patient was apparently older 10 years back. Then he developed sudden onset of palpitation in one function, which was regular, not associated with syncope and relieved after some medication.
Is it always exertional?
No, sir, not exertional.
Then what?
It is sudden in onset and sudden in offset.
Oh, okay.
That was one episode only.
Yeah, first episode. And then this palpitation episode gradually become more frequently since last 10 years. And after 6 months, this dyspnea on this palpitation is also associated with dyspnea on exertion. Initially, he was able to walk around 2 kilometers without any dyspnea. And later on, this dyspnea was gradually progressive over the period of 10 years.
Is palpitation always at rest, or it is both at rest and on exertion?
Palpitation is only at rest, and this symptom of palpitation gradually dyspnea is also started. But dyspnea, palpitation is not associated with dyspnea.
How do you know the severity of palpitation?
I didn't get it.
Even I didn't get it.
Severity of palpitation. Is it moderate or mild? How do you know?
For palpitation, there is an NYHA classification. Mostly in this case, it is NYHA grade 2 because
palpitation leads to something.
But this palpitation not associated with any syncopal.
Okay. So palpitation leads to syncope, angina.
No.
This is really important.
Yeah, I mentioned this palpitation not associated with any syncope and unconscious and relief after some medication.
Regularly you go?
This is regularly. According to patient, mostly he feel like a regular nature.
How long does each episode last? How long does each episode of palpitations last?
I still don't get your symptomatology. Is it, are the symptoms intermittent or they have been persistent for last 10 years that you said? You said ago the patient had palpitation and dyspnea. Then you said it was one single episode.
This history started with single episode of palpitation in one function. then this palpitation frequencies gradually increase. Suppose during the last 10 years, this palpitation occurs only at 1 and 2 months, but gradually it occurs during 15 days or 20 days of duration.
So he's been getting
Episodes of palpitation, which is
okay. So he's been getting episodes of palpitation.
yes, sir.
And when he gets this palpitation, he also gets breathlessness.
No. They are unrelated. So now, what is the reason for these palpitations for 10 years? At rest always, episodic in nature.
Yes, mostly the arrhythmic in nature. Arrhythmic in nature.
You have to tell us the palpitations are rapid palpitations or are they slow palpitations? Did you tap and ask the patient? what the
He
palpitation
says,
This is the
Srinivas Maharaj,
rapid palpitation.
it is a regular palpitation.
is a regular
And rapid.
Is it rapid?
Rapid,
Yes,
yeah.
and rapid.
And with not associated with any syncope or unconscious.
Okay. So that makes it more. Okay.
So it is rhythmic in nature,
Yeah, mostly likely arrhythmic.
like a paroxysmal SVT.
Because there is no association with any increased frequency of urination. So I am not telling is more.
That is not a very hard symptom. Not hard point. Okay then.
So apart from that, palpitation, not arrhythmia, what is could lead to palpitation?
It may be the volume overload type of palpitation,
Okay.
but this volume overload palpitation mostly due to the during exertional. But in this case, there is
Generally, they will present throughout, it won't be like episodic.
yes episode.
So breathlessness is on exertion and palpitation is on at rest.
Yes, sir.
For how many years?
Since last 10 years.
10 years. So is this breathlessness static for the past 10 years or is it deteriorating in functional class?
Yeah, it's 10 years back, this patient is able to walk around 2 kilometers. So, and now during the last 10 years, progressively increased dyspnea. And now patient is able to only walk around half a kilometer, but he can do his routine household activity without any complaint. So mostly dyspnea is gradually progress from NYHA 2 to NYHA 3.
Yes, sir, as I have told, just go a little slowly. We are unable to get what you are saying. Okay, please talk a little slowly. Okay, go on.
There is no history of
So any other important, either positive or negative history?
positive history.
Any important negative history you want to add?
No, no.
Already you told no syncope, etc. Any history of orthopnea or PND
No, sir. There is no history of PND or
or pedal edema?
So
No.
what sir is asking, specifically we should highlight with negative, so it connotes some important PND orthopnea. Previously it also discussed, presence of PND orthopnea, it helps us on that. We should tell you
So negative history. There is no history of PND and orthopnea, no history of chest pain, no history of any episode of syncope or CVA, no history of long-standing fever.
Good. So how do you approach these symptoms? Is it left heart disease? Can you say with confidence or certainty? Or right heart disease, or can't you say? Can you say with any degree of certainty whether this is a left heart problem or a right heart problem, or can't you say?
Mostly left heart problem.
How?
Because a patient has complaint of palpitation, a long history of palpitation, and
No. So you said it is an arrhythmic cause for palpitation.
You have progressive breathlessness and palpitations at rest. So are we talking of one diagnosis or are we having two diagnoses?
You have already committed palpitations is due to arrhythmia. Then why do you try to say that this because palpitations are there, it is a left heart disease? So what is this relation? You understand my objection? That is what sir also is saying. So no, are there two diagnoses? One is an arrhythmic diagnosis and the other one is some structural problem, which may be correlated or associated. Later on, we can draw that inference.
But generally we should try to keep one diagnosis, one diagnosis is possible. When you're not able to do everything, then you get the second diagnosis.
But it is not possible with your description of palpitations as at rest. You have been emphatic that it's only at rest palpitation, not at all on exertion. And breathless is always on exertion. There is no way you can correlate these two with one diagnosis. Yes, sir. Is it? Yes. Okay. Now let us forget for the time being palpitations. Focus on the breathlessness on exertion. And now again answer my question, whether can you say with certainty is left heart or right heart or not?
Mostly the left heart, because there is no signs of.
No, you cannot say. You see, the only cardinal symptom of left heart is PND, which the patient doesn't have even on palpitations, at the time of palpitations.
If I wanted to ask you, correlate the two symptoms, episodes of palpitation at rest and progressive breathlessness on exertion. How can you correlate these two symptoms with one single diagnosis, and what is odd against that?
Mostly in patients with cardiomyopathy, both symptoms can be present.
No, patients with cardiomyopathy need not have palpitations at rest. They will generally have exertional palpitation and exertional breathlessness. The one condition where you will have is rhythmogenic, cardiomyopathy. You are having episodes of palpitation at rest, but you have progressive breathlessness. But the odd thing is you don't go on for 10 years, that you progress from 2 to 3.
So the natural history doesn't allow that. Or it may be HOCM associated with some bypass tract causing pre-excitation and, SVTs. So, but this is all far-fetched thinking. So you can't say with certainty this is left heart disease, because the cardinal symptom of left heart failure is, or disease is PND, which is not there. So it could be left heart or right heart disease like a pulmonary hypertension due to whatever may be the cause, or even right aortic obstruction. Severe valvular PS, patient can present with exertional breathlessness. Okay. So anything else? So it could be left heart disease. Like what kind of diseases you want to consider?
Left heart disease may be the left ventricular aortic obstruction disease.
Like?
LVOD.
No, again, there are different types of LVOT obstruction. Would you like to consider a fixed LVOT obstruction like valvular AS or a dynamic subaortic?
More likely subvalvular obstruction, because in valvular obstruction, once there is dyspnea is started, there is a very short history of. There is no such long history of dyspnea of 10 years.
Be open with your mind. Don't get the diagnosis. Such village email, village may come with long-term India versus translation. In India, probably still you could tell valvular heart is the first problem.
Heart disease maybe, cardiomyopathy and valvular heart disease.
Even cardiomyopathy won't have such a long history. And still,
Could this be mitral stenosis? See, mitral stenosis patients typically, according to all classical naturalist studies, there will be a particular functional class for a long time before they deteriorate into the next class, unless the natural history is punctuated or influenced by development of atrial fibrillation, etc. So that should be still considered here. Okay, as Dr. Srinivas Kumar has rightly suggested, first things first, common things first. So in India, you should always respect the valvular heart disease, rheumatic heart disease. Okay, then go to the other things. One is mitral stenosis. Yes, sir said ischemic cardiomyopathy strongly ruled out in view of the long history. So please, all of you bear in mind, you should approach the symptoms of a particular patient with the natural history of that particular lesion in your mind. Is it possible from the standpoint of the natural history to have this kind of symptom for this long a period? It's very important. You see, any symptom can occur in any disease. That does not mean you will consider all the list in a particular patient. You will put through the sieving, what you call, filter it by the natural history. Is it possible? This is very important. Okay. So, 10 years history of not a very progressive or rapidly declining functional class. What else other than a mitral stenosis?
It is a hypertension with hypertensive heart disease and diastolic dysfunction.
Okay. Anything else?
This cardiomyopathy, dilated
What
cardiomyopathy.
dilated cardiomyopathy? Again, it's not possible for 10 years not to have congestive heart failure.
Progressing from 2 to 3 over 10 years, dilated cardiomyopathy.
You talk.
Sir,
What kind of cardiomyopathy, if you want to consider, what cardiomyopathy we might consider with this history?
Obstructive cardiomyopathy,
Hypertrophic obstructive cardiomyopathy is very possible with the same function class of exertional breathlessness for many years before they deteriorate. This is very important. Okay. So there is a strong possibility here. And then pulmonary hypertension, idiopathic PAH, is it possible for 10 years to remain in the same state?
Patient is a male and age is around.
No, that doesn't mean anything. No, you see, there is a classical study of pulmonary arterial hypertension studied, if I remember correct, by Chitra Tirunal, Chitra Institute in India. There is a equal incidence of male and female. Equal incidence of male and female. That is, doesn't militate against the consideration of pulmonary hypertension, just the gender. Okay. What perhaps militates against the consideration of PAH in this patient is the duration again for 10 years without much deterioration. They usually succumb to it. Okay. Then?
Policy to examiner is suggesting something, which unless it's totally against it, try to accept it and try to find some distance to say it. That is just they will be helping you like that, just for the other sake.
So what is the age of the patient? I forgot.
His age is 58 years.
58. Anything else?
And past history, there is a potential.
Valvular AS you don't want to consider. Why? Again, from point of view of natural history. What is the natural history of a severe valvular AS? Untreated natural history.
And if patient is asymptomatic, severe AS, there is a long asymptomatic period. But after developing of the symptom, if dyspnea is developed, there is a mean survival age around 2 years. After developing of syncope, mean survival years is around 3 years. And after developing of angina, mean survival year is 5 years.
I 3.2 or 1.5.
5.3 syncope, angina, distributed cold versus syncope. Anyway, long history, that's why it's like 15 minutes over.
Is ASD possible with this history? Yes, it is possible. Why not? Very much possible. In an adult patient, the long history of breathlessness. Why ASD patients become more symptomatic after the age of 40? What are all the reasons for that?
Developing RV failure or
No.
Due to pH, development of the pH.
Very good. Development of pulmonary arterial hypertension. Anything else?
due to arrhythmia.
Atrial arrhythmias. Very good. Development of atrial arrhythmias.
This patient had regular.
Then what else? What other reasons for the development of deterioration in function class in an adult ASD patient? One is pulmonary hypertension. The other one is atrial arrhythmias. The third one is development of left ventricular diastolic dysfunction, age-related hypertension, coronary artery disease. For the same size of ASD, the left right shunt is increased. So increase in the left right shunt in ASD patient, in adult patient, ASD adult patient, because of LV diastolic dysfunction, that deteriorates the function class. These are three important reasons. So that is possible in this patient. You should consider it. It is not unoften that you come across an ASD in a patient of this age. Okay. Yes, examination.
My patient is conscious oriented to time, place, and person with a BMI of around 24.3 kg per meter square, saturation of 99% on the room air, pulse is 80 per minute regular, pulses difference in character, normal volume, no radial delay, no radiofemoral delay, or peripheral pulses are palpable, arterial wall is palpable. BP in the right arm is 130 by 80 mmHg, and in the left arm it is 128 by 80 mmHg. In the right lower limb, it is 144 by 84 mm.
Can you repeat the pulse, please?
Speak a little slowly so that we can.
The pulse is 80 per minute regular, pulses difference in character, normal volume, no radial delay, no radiofemoral delay, or peripheral pulses are palpable, arterial wall is palpable.
Very good. Continue.
BP in the right arm, the left arm, it is similar, sir, 130 by 80 mmHg. In the right lower limb, it is 144 by 84 mm. JVP is not raised, normal waveform are visible in the lying down position with normal respiratory variation. Hepatojugular reflex is absent. Peripheral sign of CAD is absent.
there is no sign of infective endocarditis. On CVS examination, inspectory findings are confirmed on the palpation. Chest is normal in shape and size. No
What is the
visible
apex, please?
trauma.
Can you tell about apex?
Yes, sir. Apex beat is visible in the fifth intercostal
No,
space.
you don't have to tell at your level inspection separately and palpation. Combine both and tell.
Yes. Apex beat in the fifth intercostal space, localized slightly medial to the mid-clavicular line. Apical impulse is forceful, sustained, heaving type, and it is a triple ripple in the character. It is LV type. No parasternal heave is
Apex is not ripple. There is a triple ripple at the apical area. Both are, there is a difference between the two. Okay.
and, no parasternal heave. P2 not palpable. LVS3 no palpable. On percussion, river dullness in the right side fifth intercostal space. Right heart border is substernal. Left heart border correspond to the apex. On auscultation, S1 is normal. S2 is narrow split. S4 present, no S3. At the mitral area, there is a grade 2 by 6, a high pitch pansystolic blowing murmur, blowing in character, which is best auscultated in the left lateral position at the end of the expiration with the diaphragm of the stethoscope, and it is not radiating.
No, the description should be more complete. Description of the murmur should be more complete. Can you repeat again? Murmur description.
The murmur is grade 2 by 6, high pitch pansystolic murmur, blowing in character, which is best heard in the left lateral position at the end of the expiration with diaphragm of the stethoscope, and it is not radiating. Not radiating, sir. In the third intercostal space.
No.
left-
Anything, have you checked it with some kind of dynamic auscultation about this one?
Yes, sir. It increases on the expiration, sir.
Any other thing?
No. We are
Yes.
talking about this murmur.
Any other thing you have to do, especially when you have such findings?
So decreases with the Valsalva maneuver, and the sir decreases on the standing also.
Hand grip, have you
Hand
checked?
grips increases.
Hmm?
So it decreases on the hand grip, sir.
Decreases.
It's pansystolic murmur at the apical area.
My question is, have you tested the murmur with hand grip? Isometric exercise by hand grip.
Yes, sir.
So what is the effect of that on the murmur intensity?
It increases, sir.
Decreases. Okay, continue.
In the left third intercostal space, there is a grade 3 by 6 crescendo, decrescendo, high pitch ejection systolic murmur, which increases on standing, decreases during the strain phase of the Valsalva maneuver, and best heard with the diaphragm of the stethoscope. It is not radiating to the carotid.
Increasing in the strain phase.
Increases on the strain phase of valve. Strain
But
phase of
standing
valve.
from squatting? From squatting to standing?
Squatting to standing, it increases, sir.
Increases. So first complete the description of the murmur at rest. Complete. Then tell about the dynamic auscultation. Don't mix up both.
Yes.
Okay. No, repeat, please repeat. No, please repeat.
Repeat. At the left third intercostal space, grade 3 by 6 ejection systolic murmur, crescendo, decrescendo.
Is it rough, rasping, or is it harsh? Something like that you have to tell. Always there should be adjectives used about the character and intensity and pitch of a murmur. Don't simply say ejection systolic murmur.
Harsh.
Okay, harsh.
And best heard with the diaphragm of the stethoscope, it is not relating to the character. On dynamic auscultation, murmur increases during the strain phase of Valsalva maneuver, and it also increases during the standing position.
From squatting to standing. Okay, anything else? Again, during your examination, by chance, was there an ectopy occurring? If it were to occur, what would you expect the murmur to behave like after the ectopy?
So after the ectopic extrusive murmur increases.
No, we are not talking about it, HOC murmur.
And AS.
We are all only talking about perhaps an LVOT murmur because you have a heaving apical murmur,
Sir,
LV
if it
apex.
is due to the valvular obstruction at the LVOT murmur, it decreases after the ventricular premature.
Okay, we'll discuss that a little later. Continue.
Sir, other systemic examination.
Okay, now give your diagnosis.
left ventricular outflow tract obstructive disease, most likely HOCM, with a mild pulmonary venous hypertension, no PH, in normal sinus rhythm, with no evidence of infective endocarditis in NYHA class 3.
Describe two markers.
Yes, sir, with mild MRs, moderate MRs, mitral regurgitation.
Regurgitation, not MS.
Yes, sir, mitral regurgitation.
Okay. So why do you say it LV obstruction? Why do you say it is dynamic LV obstruction? Why is this not that the apical murmur is a conducted murmur of HOCM itself? Why do you say there is an MR in addition to HOCM?
The predominant murmur is the, sir,
No, LV obstruction. Why?
because on the dynamic auscultation, sir.
No. See, you say LV obstruction just because of dynamic auscultation? You say LV obstruction because of heaving apical impulse, a palpable LVS4 and auscultable LVS4.
Because of giving apical impulse, sir.
An early peaking murmur or is it a late peaking murmur? The peaking of ejection systolic number is very important. Trying to distinguish between
Late peaking murmurs.
Okay. Okay, we accept it is an LV obstruction.
it is a feature of valvular aortic stenosis. Okay. If you have significant valvular aortic, so what are the other features of significant valvular aortic stenosis murmur?
No, how to differentiate? That's what sir is trying to ask. When you have an LV obstruction, you want to know whether it is a dynamic LV obstruction versus a fixed valvular obstruction. No, first go with the pulse. Is pulse useful?
Different, sir.
No. No, how is the pulse in a severe valvular AS? How is the pulse there? How is the pulse in a severe valvular AS?
No rising and late peaking.
So pulsus parvus et tardus. So when you palpate the carotid pulse, if it's a pulsus parvus et tardus, it goes in favor of valvular AS. On the other hand, if you palpate a brisk pulse, which is bisvariant in nature, it goes in favor of a HOCM. So pulse is very useful here. Then coming to the apical palpation of apex, how does it help?
Sir, it is forceful and sustained, so most likely due to the.
So you will have a heaving apical impulse in both situations. You will also have a palpable S4 in both situations, but you have a triple ripple where the apex is bifid in nature that goes in favor of a HOCM rather than this thing. Okay. You have S4 plus heaving impulse only, then it is what you call valvular AS. If you have S4 plus bifid impulse, if you have a bifid impulse, it helps you to suggest that it is a HOCM. Then what else? The conduction of the murmur to the carotid goes in favor of a valvular AS. There will be no carotid conduction in HOCM. The location of the murmur may not be much useful. Then second heart sound, will it be useful?
That's only in severe aortic stenosis.
It is mostly single type or narrow split. Sir. Narrow split or in very severe it is.
Where do you get paradoxical split? In valvular AS more often or in HOCM more often?
Valvular, yes.
So you'll get in HOCM also. Okay. So how do you make out a paradoxical split when you are clinically examining the patient?
Paradoxical splitting.
Huh?
Repeat the question.
How do you diagnose a paradoxical split when you are examining the patient by auscultation?
Sir, on auscultation, if during the inspiration there is a single sound, and on the expiration, if there is a both the sounds are heard, E2 and P2 are audible, sir, then it is a paradoxical.
Again, do you make him take deep breath or deep expiration, do a deep expiration, or is it normal inspiration? That is important. So, okay, then what else? Now you go to dynamic auscultation. So how does dynamic auscultation help to differentiate a fixed valvular obstruction versus dynamic subaortic obstruction?
Type of murmur also is slightly different. And now dynamic auscultation, how is it different?
So on dynamic auscultation, if it is due to the valvular obstruction, on sir Valsalva, it is the murmur is decreases, sir.
Valsalva means what? Which phase of Valsalva? Huh?
During the strain phase of the Valsalva.
Straining phase of Valsalva. Okay. Then?
And from the squatting to standing position, murmur also decreases, sir, in the valvular.
What are all the murmurs in your clinical cardiology that get accentuated when the patient stands from squatting and also on straining phase of Valsalva. One is HOCM. What other murmurs?
Mitral valve
Prolapse.
prolonged, murmur prolonged, sir. in the
So
mitral
what is the mechanism of increase in intensity of HOCM murmur during the straining phase of Valsalva? Why does it happen?
valve. Sir, due to the dynamic. During the Valsalva phase of murmur, there is a during the strain phase of Valsalva, there is a decrease in the LV blood flow, due to which there is a dynamic dynamic outflow tract.
So there is a reduction in the preload.
Sir.
Okay.
Yes.
When there is a reduction in the preload, the alveolar obstruction increases. Reduction in the preload, reduced afterload, increased contractility. These are the three reasons when which cause the increase in the alveolar obstruction. So because of reduced preload, there is an increase in this thing. So what else? No, finally, one important this thing I have already asked. If there is an ectopic occurring, or if you give an ectopy during cath, what are the differences that happen hemodynamically between HOCM versus fixed AS?
The Braunwald phenomena, sir.
Broken burrow, Braunwald sign. Okay. What is it exactly?
Sir, during this, sir, if after the VPCs, so there is a pressure difference is increases, sir, in the HOCM.
So,
Aorta and diaphragm.
So what will happen during the post-extrasystolic potentiation? There is a prolonged pause. So diastole is increased. So preload increases. So increase in preload should reduce the alveolar obstruction in HOCM. But by Frank-Starling law, increase in preload also increases the contractility. So the effect of the increase in contractility far much outweighs or predominates over the effect of preload, increase in the preload, thereby increases the alveolar obstruction. What will happen in fixed alveolar obstruction? In fixed alveolar obstruction also, gradient will increase. So clinically, the murmur will increase after an ectopy in both HOCM as well as valvular AS. The only difference is pulse pressure is reduced in HOCM, whereas pulse pressure is increased because of increase in cardiac output in valvular AS. This is the difference between the two.
I will look at this. I will look at the.
This is the normal sinus rhythm with the normal axis, sir, with the left ventricular hypertrophy with the pressure overloads, LVH with LV strings, sir.
If the T-wave inversion were deeper, then that is a feature of what type of
Pressure overload situation.
Primary cardiac. This is that called.
Yeah, you can read those there.
Yes. So the echo diagnosis shows that this is the case of hypertrophic obstructive cardiomyopathy, and there is a asymmetrical septic hypertrophy. IVS is 20 millimeters, posterior wall is 15 millimeters, and there is a resting gradient across the LVOT of 68 millimeters of mercury, and grade 3 SAM is present. So how do you define asymmetrical septic hypertrophy?
So if the LV and diastolic wall thickness is more than 15 mm.
Difference between the IVS and the posterior wall ratio is more than 1.5.
Yes. That is.
What is the current understanding of the reason for dynamic obstruction? Mechanism of dynamic obstruction.
There is a mostly first is due to the venturi effect of the
Yeah, that was previously thought of like that. What is the current understanding? Drag force of the flow, an abnormally positioned anteromitral leaflet. Okay. Then, because of the gradient between the difference in the pressure between the LV and LVOT, LV body and LVOT, that will further push the mitral leaflet towards the septum, hypertrophied septum. Okay. We'll stop here. Yeah, we'll stop here. Yeah.
Sir, is the resting gradient is more than 62, I think, more than 50 mmHg, sir. 68 mmHg, sir. So we can go for the, sir, septal,
First we go to medical treatment, beta blocker or calcium channel blocker. If patient is even symptomatic after the beta blocker or calcium channel blocker, then we go to the.
So if your patient doesn't respond to beta blocker, which is the calcium channel blocker that we use?
Verapamil or.
Yes, only verapamil.
What is the latest drug that is being,
Dipyridamine is.
no, latest drug?
Mavactam, sir.
Latest, what is the second category of drug?
So myosin inhibitor, Mavactam.
Before that, sir, is asking, other drugs which we used to use before.
Which has a profound
Dihydropyridine.
disopyramide.
Yeah, so you use these first two drugs, and if your patient is still not responding, then you use mavacamten, not available right now in India. And
So one thing I will tell from echo and correlating with your examination and your conclusion, there is no significant mitral regurgitation in the echo. And the murmur which you said you have had at the apex has decreased with your hand grip. That is strongly goes against a mitral regurgitation. You understand? So same murmur of alveolar obstruction you had at the apex also. I think we'll conclude this session here. Thank you very much. You have done well. Okay.
Thank you. Just before we close, anybody in the audience who wants to ask final chance for you regarding this case or anything else before we close? Anybody want to take the mic and ask something, please welcome. Close. Okay, thank you.
Thank you. Okay, thank you so much. So with that, we come to the end of this meeting. I hope you had a useful these 2 days and must have been benefited with whatever the lectures and whatever the case presentations we had so far. How do you feel in general? I can't hear. Right. Thank you. There are feedback forms are there and give your honest feedback. The reason is not that I'm going to tell the faculty members, but this is our 7th session. Every year we are doing it, and our endeavor is to keep improving every time, because sometimes some topics are missed, some topics are overemphasized, some topics are underemphasized. Some people have better presentation skills and some have lesser skills. But eventually we really want to, so it should work in total. That means your doubts should get cleared, and probably some lectures, it may be difficult for you to follow during the time of lecture. Like yesterday I was telling that echocardiogram, I really suggest that, go through that recorded version at leisure. You will get a lot of salient features. So that way, that is the reason I need your honest feedback on speakers and whatever it is you have. Okay. Primarily, our intention is, because I'm requesting all my colleagues, they are all coming from different places of the country, just to spend time and teach you. We have only one interest, that is to teach, nothing else. No other, any other interest in this particular meeting is. So with that, we come to an end. I thank all the patients who have made their efforts to come here. Thank you so much, sir, because they too are busy in their own things, and we requested them because there is excellent cases there. So thank you once again. So with that, we come to an end. Hopefully we'll see you the next year, whoever is in first year and second year, third year for you. All the best. Thank you.
Hello. Will